Good morning, everyone, and welcome to week number 5 of our 10-week seminar retreat program. This means we have officially reached our halfway point. Last week, I mentioned some alarming statistics, if you recall, that in America, every day, 2,500 people attempt suicide and 100 people die by suicide. Depression is twice as common in women than men. However, men commit suicide 3 times more than women. WHO put out the following numbers that around the world there's 264 million cases of depression each year, and 800,000 deaths occur because of suicide each year. When so many people are dying unnecessarily, the question is, what are we doing about it? Unlike the coronavirus, where we tragically haven't discovered a cure yet, depression and anxiety has many effective and established methods of treatment. Research shows that once a treatment plan is begun, almost 85% of the people feel better in just 6 to 8 weeks. Treatment methods do not necessarily have to be medication or pharmacological. Oftentimes, the first line of treatment is non-pharmacological interventions. Simple things like lifestyle or behavioral changes, changing our thought patterns, being mindful of not falling into unhealthy ways of thinking, simple things that make a big difference. But it takes a conscious effort to use and utilize these proven methods, which are simple to follow if we know how. The sad reality is that despite all of the tools and treatments available, this worldwide pandemic of depression is getting worse. And by 2030, WHO has predicted that it will overtake cancer, stroke, and heart as a leading cause of disability in the world today. 2030 is only 9 years away. So it'll come here before you know it. And in many ways, depression should be thought of as something that's more akin to diabetes. It's not something that you can will away or snap out of. The only way to bring it under control is whether it's your depression, your anxiety, or your blood sugar, you have to implement a plan of action in your life and stick to it. We cannot fight an enemy without knowing and understanding it. Like any problem in life, if we fail to do anything about it, it will only get worse and worse until it silently kills you. They say diabetes is a silent killer because you don't realize the damage that high blood sugar does to your body and organs until it is too late. In many ways, depression, stress, loneliness, anxiety is a silent killer because no one else around you realizes the damage that is happening until it's too late. Most people suffer silently without getting the help they need time. The government of Canada recognizes depression as a form of disability, but not diabetes. If the government can recognize the seriousness of it, why can't we as a community do so as well, so that we can reduce the silent suffering? Famous people have anxiety and depression: Leonardo DiCaprio, David Beckham, Adele, Harrison Ford, John Mayer, and of course, Justin Bieber. When I tried to find out Indian celebrities who have been vocal and public about suffering from mental health issues, I couldn't find many, but only the two that I came to know of was Amitabh Bachchan and Shah Rukh Khan. I'm not sure to what extent, but I think this speaks to the fact that Indian culture in general has a more stigmatized view of these topics than maybe Western cultures. People suffer in silence. We don't have a problem talking about a coronavirus pandemic, for example, but we do have a stigma when it comes to talking about any mental health problem. And these problems inevitably get worse the longer it goes unaddressed and untreated. So whether it's a cultural stigma, or if it's a personal belief, maybe it's our fragile egos or lack of emotional maturity that's holding us back as a community from open dialogue about the negative stigma that's preventing us from saving a lot of unnecessary deaths by suicide and depression and suffering. It's easy for medical professionals to talk to other medical professionals, but what we need is to remove the stigma from the general population. Coronavirus will come and go, but unfortunately our population is going to suffer more from depression and anxiety unless we remove the stigma by talking about it and talking about how we can treat it effectively. People are worried about the upcoming pandemic or twin pandemic with the flu and the corona. With this extended period of social distancing, isolation, and lockdown, we really need to worry about the increase and spike in mental health issues as well. The status quo as it is now with regards to open dialogue about mental health issues has to improve. And I just want to talk about what exactly stigma means. Stigma is a negative, it's a harmful stereotype. It's an artificial construct of society, of our culture. I remember 20 years ago when wearing a prescription eyeglasses was heavily stigmatized. It was looked down upon. Nobody wanted to be seen wearing a prescription eyeglass. It was something that people got ridiculed over. And people were so ashamed to wear eyeglasses that they would refuse to wear it to school. Children would refuse to wear it to school. And because of that, you wonder how many children grew up finding it difficult to understand the lessons being taught in the classroom by the teacher because of being ashamed to wear prescription eyeglasses. And now it's a complete reversal. Wearing eyeglasses is a trendy thing to do, and in fact, people trend to seek out the larger sunglasses. The bigger the sunglasses, is more fashionable now. So stigma arises out of a lack of awareness, maybe a lack of education or a lack of perception of the complications or the nature of a condition. If you look at where else in our culture we hear the word stigma, it's not only with regards to certain health conditions or mental health issues. It also has to do with we see it in our religion, in the Bible. We see that stigma was a word that was used to describe the markings that was seen on the hands and feet of Jesus Christ when he was crucified, right? Stigmata is a plural form of stigma. And, my fellow listeners, my fellow human beings, my only request today is that we let go of stigmas or these harmful stereotypes that we currently hold on to with regards to different health problems, so that they are no longer a metaphorical nail which pierces through the minds of those that suffer these illnesses in silence. But the good news is that after Jesus' resurrection, the stigma became a symbol of victory over pain and suffering, over negative stereotypes, negative thoughts and beliefs. Something that was seen as a mark of disgrace with the crucifixion by the Roman Empire went on to become a sign of divine favor, of victory over defeat. And later on, we saw stigmas appearing on the bodies of saints like Saint Francis of Assisi and other people who went out of their way to try to imitate stigmata, sign of their devotion. So let's reflect on what are some of the healthy stigmas or unhealthy negative attitudes and stereotypes that we need to eliminate from our community so that we can help those who suffer in silence. So today we'll be continuing on the same topic and theme as last week, which is depression and anxiety. There's a lot more that needs to be said about it. And we have different experts from different fields speaking to us today. And we have more mental health experts, social workers, pastoral counselors, and we're also fortunate today to have with us a neurologist as well. I'd like to begin today's seminar with a quote by Alvin Toffler, who's a famous American writer. He said that the illiterate of the 21st century will not be those who cannot read or write. It will be those who can learn, who cannot learn, unlearn, and relearn. Let us not be illiterate due to our inability to unlearn our negative stigmas, a healthy attitude, and an understanding. I'm really looking forward to hearing today's speakers. I humbly request Reverend Father Jibin Kurian, the vicar of St. Ignatious Knanaya Jacobite Church, Toronto, to begin today's seminar program with an opening prayer.
ദൈവത്തിൽ ആശ്രയിച്ചുകൊണ്ട് നമുക്ക് ഇന്നത്തെ സെമിനാർ പ്രോഗ്രാം ആരംഭിക്കുകയാണ്. നമുക്ക് പ്രാർത്ഥനയോടുകൂടി ഇന്നത്തെ സെമിനാർ ആരംഭിക്കാം. കാരുണ്യവാനായ ദൈവമേ, നല്ല സ്വർഗീയ പിതാവേ, ദൈവമേ, ഞങ്ങളുടെ ഈ പ്രോഗ്രാം ഇതിന്റെ പകുതിയോട് ആയിരിക്കുകയാണല്ലോ. ഏറ്റവും അനുഗ്രഹകരമായിട്ട് ഇത് നടത്തുവാനായിട്ട് ഞങ്ങൾക്ക് സാധ്യമായതിന് നിന്നെ സ്തുതിക്കുന്നു, സ്തോത്രം ചെയ്യുന്നു. എല്ലാം അനുഗ്രഹകരമായിട്ട് തീർക്കുവാൻ യോഗ്യമാറാകണമേ എന്ന് പ്രാർത്ഥിക്കുന്നു. കർത്താവേ, ഇതിൽ സംസാരിക്കുവാനായിട്ട് കടന്നു വരുന്ന ആളുകൾ, ഇതിൽ ജോയിൻ ചെയ്യുന്ന ആളുകൾ എല്ലാവരെയും പ്രത്യേകമായിട്ട് നീ ഇവിടുന്ന് അനുഗ്രഹിക്കുമാറാകണമേ എന്ന് ദൈവനാമത്തിൽ ഞങ്ങൾ അപേക്ഷിച്ച് പ്രാർത്ഥിക്കുകയാണ്. എല്ലാ കൃപകളാലും ഞങ്ങൾ ഇവിടുന്ന് നിറയ്ക്കുമാറാകണമേ. പ്രത്യേകമായിട്ട് ഇന്ന് ഞങ്ങൾക്ക് ക്ലാസുകൾ നൽകുവാനായിട്ട് കടന്നു വന്നിരിക്കുന്ന നിന്റെ എല്ലാ മക്കളെയും എതിർക്കാര്യങ്ങളിൽ ബഹുമാനപ്പെട്ട അച്ഛനെയും അതുപോലെ തന്നെ പ്രിയപ്പെട്ട ഡോക്ടറെയും സോഷ്യൽ വർക്കറെയും എതിർക്കാര്യങ്ങളിൽ ഏൽപ്പിച്ച് പ്രാർത്ഥിക്കുകയാണ്. അവരിലൂടെ നല്ല ഒരു ക്ലാസ് ഞങ്ങൾക്ക് ലഭിക്കുവാനായിട്ട് ഞങ്ങൾക്ക് ഇടയായി തീരണമേ എന്ന് പ്രാർത്ഥിക്കുന്നു. പല രാജ്യങ്ങളിൽ നിന്ന് ജോയിൻ ചെയ്തിരിക്കുന്ന എല്ലാവർക്കും ഇത് നന്മയ്ക്ക് കാരണമാകണമേ എന്ന് പ്രാർത്ഥിക്കുന്നു. ആയത് ഞങ്ങൾക്ക് ജീവൻ വെച്ച യേശുക്രിസ്തുവിന്റെ ഏറെ നാമത്തിൽ ചോദിക്കുന്നു. പിതാവേ, കൃപയോടെ കേട്ട് ഉത്തരമരുളുമാറാകണമേ. ആമേൻ. ദൈവ തിരുനാമം മഹത്വപ്പെടുമാറാകട്ടെ. പ്രിയപ്പെട്ട ജാക്ക് ഓർമ്മപ്പെടുത്തിയതുപോലെ നമ്മൾ കഴിഞ്ഞ ആഴ്ച ചിന്തിച്ച ക്ലാസിന്റെ കണ്ടിന്യൂവേഷൻ ആയിട്ടുള്ള ടോപ്പിക് തന്നെയാണ് ഇന്ന് നമ്മൾ ചിന്തിക്കുന്നത്. പ്രത്യേകമായിട്ട് ഇന്ന് സ്പീക്കേഴ്സിന് കൂടുതൽ സമയം, അല്ലെങ്കിൽ അവർക്ക് പോകേണ്ടതായിട്ടുള്ള ചില ആവശ്യങ്ങൾ ഉള്ളത് കൊണ്ട് അവർക്കായിട്ട് സമയം കൂടുതലായിട്ട് നൽകുകയാണ്. അതുകൊണ്ട് കൂടുതലായിട്ട് ഞാൻ ഒന്ന് സംസാരിക്കാൻ ആഗ്രഹിക്കുന്നില്ല. ഇന്ന് നമുക്ക് സ്പീക്കേഴ്സായിട്ട് കടന്നു വന്നിരിക്കുന്ന ബഹുമാനപ്പെട്ട ഫാദർ പയസ് മല്ലിനാലച്ചൻ, അച്ഛനിപ്പോൾ USA സോഷ്യൽ വർക്കില് ഡോക്ടറൽ സ്റ്റഡീസ് നടത്തിക്കൊണ്ടിരിക്കുന്ന ബഹുമാനപ്പെട്ട അച്ഛനെ സ്വാഗതം ചെയ്യുന്നു. അതുപോലെ തന്നെ ഡോക്ടർ ജോസഫ് ചെറിയാൻ പെരുമ്പള്ളിച്ചിറ, അദ്ദേഹം കാനഡയിലെ ന്യൂറോളജിസ്റ്റ് ആയിട്ട് വർക്ക് ചെയ്തുകൊണ്ടിരിക്കുന്നു. പ്രിയപ്പെട്ട ഡോക്ടറെ ഈ സമയത്ത് പ്രത്യേകമായിട്ട് സ്വാഗതം ചെയ്യുന്നു. അതുപോലെ തന്നെ നമ്മുടെ ഇടവക അംഗമായിരിക്കുന്ന പ്രിയപ്പെട്ട ശിവ ചേച്ചി, കഴിഞ്ഞ 24 വർഷങ്ങളായി കാനഡയിൽ സോഷ്യൽ വർക്കറായിട്ട് വർക്ക് ചെയ്യുന്നു. പ്രിയപ്പെട്ട ശിവ ചേച്ചിയെ സ്നേഹത്തോടുകൂടി സ്വാഗതം ചെയ്യുകയാണ്. 3 സ്പീക്കേഴ്സിനെയും ടൊറന്റോ സെന്റ് ഇഗ്നേഷ്യസ് ക്നാനയ ദൈവാലയത്തിന്റെ നാമത്തിൽ ഈ സമയത്ത് പ്രത്യേകമായിട്ട് സ്വാഗതം ചെയ്തുകൊള്ളുന്നു. അതുപോലെ തന്നെ ഇന്ന് പല രാജ്യങ്ങളിൽ നിന്ന് ഇതിൽ ജോയിൻ ചെയ്തിരിക്കുന്ന എല്ലാവരെയും ഏറ്റവും സ്നേഹത്തോടുകൂടി സ്വാഗതം ചെയ്തുകൊണ്ട് ഞാൻ എൻ്റെ വാക്കുകൾ സംഹരിക്കുകയാണ്. ദൈവനാമം മഹത്വപ്പെടുമാറാകട്ടെ.
Thank you, Jibin Achan. Achan Parnolane, we're very fortunate to have with us today Dr. Joseph Chirian Perumbalichira, Associate Professor of the Division of Neurology under the Department of Medicine at McMaster University. He is a staff neurologist at Hamilton Health Sciences Hospital Network, where he has been working since 2015. Dr. Joseph is not just a physician, but he's also an accomplished researcher with 48 peer-reviewed publications and authoring 5 book chapters. His research interests include clinical epilepsy and clinical neurophysiology, including automated analysis of EEG, electroencephalogram. He obtained his MBBS from Calicut Government Medical College in 1991, finished his residency and obtained his MD internal medicine in 1994 from BJ Medical College and Sassoon Hospital, Pune, followed by obtaining his DM in neurology from Sri Chitra Tirunal Institute of Medical Sciences and Technology, Trivandrum, in 1997, where he also taught as assistant professor until 2003. From 2003 till 2015, he moved to Netherlands, where he worked as staff neurologist and clinical neurophysiologist at Erasmus MC University Medical Center, Rotterdam. He defended his PhD thesis on improvements in neonatal brain monitoring after perinatal asphyxia at Erasmus University, Rotterdam in 2010. In 2014, Dr. Joseph completed a 1-year clinical fellowship in pediatric epilepsy at the Mayo Clinic, Rochester, Minnesota, before moving to Canada. We are so fortunate to gain insights from experts in our Malayali community, especially during this time of social isolation. And we're so thankful that Dr. Joseph has taken time away from his clinical practice and research to speak to us today. I think that awareness of neurological disorders is one area that is not often discussed enough in the general community, and especially our South Asian or Indian culture in particular. And when we look at a lot of the topics or symptoms that I mentioned about before with regards to mental health, depression, a lot of it sometimes is mistaken as a psychological issue when there's actually a lot of underlying neurological etiologies behind their diseases. There might be concurrent problems such as dementia, Alzheimer's, a lot of things that older adults especially have to deal with and face. And also, something I mentioned about stigmas is something that we see with a lot of neurological disorders. As Malayali community, we know that we need to be aware of cardiac issues. We're always seeing cardiologists and doing all the tests in time. But unfortunately, the awareness about neurological disorders is not as publicized as other health disorders. And I think that it's something that we need to talk about more as a community, as a society, as a culture. And so hopefully we can gain more insight from listening to Dr. Joseph speak today. So it's with great pleasure that I invite Dr. Joseph Chirian Perumbalichira as our first speaker in today's seminar.
Thank you very much, Jack. I would like to express my gratitude to Dr. Punar and Jacob for inviting me and giving me this opportunity to interact with you. It looks like a very vibrant and active community here. I'm so happy to see that you've been discussing things about, meaningful life, mindfulness. I think in this challenging times of the pandemic, we realize acutely how detrimental the social isolation can be. It's not only the illness that strikes you, but it's the social isolation. So I was very happy to get this invitation to talk about 3 common neurological conditions that we encounter in day-to-day life. I'll be briefly talking about stroke and dementia and my own area of specialization, that's epilepsy. So rather than burden you with a lot of epilepsy talk, which you may or may not use, I thought it was more valuable when Punaran suggested that just give 8 minutes each for these topics so that I am able to kind of light a spark where you are becoming more curious to know what these things are. I think any journey starts with awareness and knowledge. And we need more and more people to be aware of things so that you can advocate for yourself or a person who you love who is affected by these conditions, or even somebody in the public, because if you look at the parable, the story of the Good Samaritan, it was not the Pharisee or the merchant, or it's the Good Samaritan who was person who was lying by the wayside, and total stranger who helped him. So the same thing can happen. Any one of us could be struck down by a stroke or could develop dementia, And a lot of known and unknown people come into our lives and help us. And so I think starting with the knowledge and understanding of these conditions, I think it's a very, very important step. So, and another thing I will briefly touch upon is the stigma. So I think that is also something we can talk about briefly. So without further ado, I'll just try to share my screen and just let me know if I'm. So the three things we'll talk about is stroke, dementia, and epilepsy. Many of you are, physicians. You already have maybe a loved one who has suffered from a stroke or dementia or have seizures. Unfortunately, because of the Zoom, I cannot talk to you and have a show of hands. And a lot of you, the screens are quite dark. But feel free to use that chat function. If you just click there, and there's a chat function, and you could just type in your questions, or you say just raise your hand, and feel free to interrupt me at any moment. So Jack, if you could keep an eye out for the chat window, and let me know if I just need to stop and address that question. I will be happy to do so, or we could have this discussion at the end of the talk. All right. So have any one of you ever suffered a stroke? Or anybody in your family who has suffered a stroke? So I don't see a show of hands, but this is the limitation of the Zoom, but that's all right. So why is it important to talk about stroke and TIA? TIA is another acronym. It means transient ischemic attack. This could be a forerunner of a stroke. So it's important to recognize these conditions. And this is from the American Stroke Society or the National Institute of Health, as well as Stroke Canada. So these are the three points you have to keep in mind. Is there an abrupt onset of drooping of one side of the face? Ask the person to lift up the arms, and if you see one arm is kind of drifting down, or is the speech becoming slurred or jumbled? Okay, this could be a sign of a stroke or what we call as a transient ischemic attack. Then there is no time to lose, because time is brain. And then we say call 911 straight away. So again, face drooping, arm weakness, speech difficulties, time to call 911. Okay. Sometimes this may not be a stroke. It could be something like hypoglycemia, or somebody is developing some other medical complication. That doesn't matter. Okay. Because it's important not to miss a stroke. So we'll not be talking about the stroke mimics here. I'll just talk about stroke. All right. So then it's time to call the 911, take the person to the emergency, and I'll tell you why. There could be some other additional symptoms of stroke. Sometimes it's not so straightforward. It could be a sudden numbness of or weakness of face, arm, leg, or especially on one side of the body, sudden confusion. So that stroke is usually dramatic. It just comes out of the blue. One moment the person is fine, talking to you happily, and suddenly he becomes confused, has trouble speaking or understanding speech. Or you could have sudden trouble seeing in one or both eyes, or difficulty with walking, or abrupt onset of dizziness, loss of balance or coordination, or difficulty in swallowing, or sudden severe headache with no known cause. And this could, could be a warning sign of a subarachnoid hemorrhage or an intracranial hemorrhage or a bleed. Now, the faster you give treatment to the person, you can save life and also salvage brain tissue, because it's the brain that makes us who we are, right? Like each person is unique, and all our faculties are important, and different parts of the brain subserve different functions, such as memory, language, motor functions, sensory functions, or higher level processing. And what happens in stroke, as you can see in this picture below. So I don't know whether you are able to see the, let me just try to get a cursor here. So the laser point. Okay, are you able to see the pointer? See the laser point. So this is a picture of the brain, and this part of the brain is shown in dark color. So that's what happens in stroke. So that part of the brain suffers from decreased blood supply, oxygen, and nutrients. And if this is not addressed quickly, say within a window of 3 hours, and you could suffer permanent damage. So this is, for example, the left side of the brain, and this is the area we call as the frontal lobe. And this is very close to the area we call the Broca's area, or needed for expressive language and speech. So you can imagine if you suffered a permanent injury to this part, and if you have to go on for the rest of your life without being able to speak or to communicate or to meaningfully convey your ideas to other people. It's not only about speech, but also writing, language, reading, everything can get impaired. So you can see how catastrophic this is, okay? And this contributes hugely to the morbidity and disability worldwide. That is the sequelae of the stroke. So that's very important. Quick stroke recognition and treatment can save you from disability or even death. So 85% of them are ischemic stroke. That means a blood vessel supplying a part of the brain is blocked by a clot. So less commonly, 10 to 15%, it could be a bleed or a hemorrhage. So if it's a hemorrhage, we cannot use clot busting treatment. So what is clot busting? The person is brought into the hospital. He or she has a urgent CT scan of the brain, which confirms there is a infarct or a stroke. And there are criteria to be met before we can decide whether it's safe to administer this thrombolysis, which is a medication that can dissolve the clot and can improve blood flow to the part of the brain that's affected. And if it's administered within 3 hours, and that could result in significant improvement or complete reversal of the injury. And there are other stroke treatment options. Unfortunately, this is not as widespread as the intravenous thrombolysis. So this is for patients who are eligible, and if the intravenous or IV thrombolysis doesn't open up the blood vessel, so then the person could be brought to a specialized center. So I'm fortunate to be working in such a center. We have 4 persons on call around the clock. So 3 of them, one of them is a radiologist, 2 are neurosurgeons. One is a neurologist trained in interventional radiology. So what they basically do is bring the patient into the cath lab, very similar to cardiac catheterization, but then the person undergoes an angiogram to see which blood vessel going to the brain is blocked. And then by putting in a catheter, we are able to kind of, so this is one such device. Either put in do a balloon angioplasty and put in a stent, or use a mechanical thrombectomy. So it's something like you pass a catheter and try to remove that clot physically or manually. Okay, so patients must meet certain criteria to be eligible. So when you see all these steps, you know that only a population of people who are aware of these symptoms would be able to seek help. So there's no point in saying that I've got a fantastic hospital around the corner in the block, but if the person or his family or his acquaintances are not aware that this is what is happening, and do not have the presence of mind to access that service, so that's precious time lost. And to make matters worse, in this day of nuclear families or older person living by himself or herself, it can have tragic consequences. So what are the risk factors for stroke? So there are both modifiable and non-modifiable risk factors. So what are the non-modifiable risk factors? One would be age. I can do nothing. I've crossed 50, so I can do nothing about that. And that's the inexorable process. All of us are born, we age, and then we pass from the face of the earth. And so that's something we cannot do anything about it. Your gender may have a role to play, and you may have some genetic traits which will make you prone for developing the stroke, and you cannot change your parents, right? So these are things we say we cannot modify these risk factors. But there are a lot of risk factors we could probably do, fantastically well. And a lot of the advances the modern medicine claims, for improving your quality of life or your longevity, is because of the treatment of these risk factors. So these are not important not only for the management, prevention of stroke or heart disease, even for vascular dementia. Addressing these risk factors would be so important. So people would be thinking, we have a high-tech hospital around the corner, cardiac cath lab, you have the gamma knife or cyber knife for treating the tumors. Did that really add to the longevity in the world population? Probably not. So what has really resulted in increasing the longevity? You can imagine even the so eminent kings like Chitra Tirunal, or Uttaradam Tirunal, these were the kings of Travancore. And at that time, the life expectancy was 45 to 50 years. So now you can imagine even a lay person or somebody who's not royalty or rich could have the life expectancy of 70 to 80 years. And this is just due to these improvements in the medical care, so much about the prevention and accessing routine healthcare from your family doctor. This would ensure your longevity and freedom from disability. High blood pressure, smoking, avoiding smoking, controlling your diabetes, having a healthy diet, avoiding physical inactivity, obesity, high blood cholesterol, peripheral artery disease, and this is very common in smokers. And condition where you have an irregular heartbeat, and this is called atrial fibrillation, and this can just happen in people with valve disease of the heart or spontaneously in elderly people. Once you are above the age of 60, it's a good idea to keep a watch on your heart rate. And nowadays it's so common with your smart watches, which is able to show even the ECG to know whether you have atrial fibrillation. So when the heartbeat is irregular, there's a risk that a clot may form inside the heart. So if a clot forms inside the heart, that's a really serious situation, because your heart pumps blood to all parts of your body, including the brain. So this clot can very well go from your heart to your brain and result in a stroke and other heart diseases. And then rare conditions in the blood. I just given the example of sickle cell disease. So basically your blood becomes very viscous and slow moving, and you are at a higher risk for getting the stroke. So treating those blood disorders would be very valuable or important in avoiding a stroke. So this is like a general question. We always ask, how can I make my lifestyle healthier? Because this is easier said than done. People would rather say, hey doc, can you just give me a pill? Okay, because that's the easiest one. You take a pill in the morning, and even that you have trouble remembering to take the pill. And so I have diabetes, and then to remember to take that tablet twice a day, it becomes a pain. So a simple thing like a $2 pill box you get from the Shoppers Drug Mart would be very valuable to ensure compliance. Okay, so those simple things would really help you. Avoid smoking and avoid secondhand smoke. And fortunately, people are becoming more and more aware of these things. Improving your eating habits, eating foods low in saturated fat, trans fat, sodium, and added sugars. Being physically active. Take your medicines as directed. This may seem like a very, very simple thing. Take your medicine as directed, but it's challenging. It's not something that we consciously do, but we get busy with all kind of things when we get back home. And then later in the evening, we look at our bottle, and that bottle has 100 tablets in it, and you have no clue whether you took it or not. So sometimes it's very, very inadvertent that you miss your medication, not knowingly. And get your blood pressure checked regularly. And it's important to pay a visit to your family doctor at least twice a year. So sometimes you may want to take initiative for this, because the family doctor already has 2,000 or 3,000 people he cares for. And if you don't ask for an appointment, he will say, okay, good. Okay, no news is good news. And he's probably not going to come after you. But it may be in your own interest to go at least twice a year to the family doctor. And reach and maintain a healthy weight. So generally people say, how much did you weigh when you were 25 or 30 years? That should be your healthy weight. Okay, and decrease your stress levels. And these are things which are easier said than done. And seek emotional support when it's needed. And that's so important in communities like this. So it's very heartwarming to see that you have a huge community who look out for each other, support each other. And I think that's the right path to take, and have a regular medical checkup. And how do I change my eating habits? So, so I shouldn't probably be taking more time about this, but probably you could teach me more about these. Many of you would be, following very, very healthy eating habits. Ask your doctor, nurse, or a licensed nutritionist or a registered dietitian for help. And this is a investment really, really worth making. Okay. And if you have special needs, remember that you have to kind of pay attention to that. If one member in the family have this issue, high blood pressure, and maybe you need a low salt diet, then it should be that the whole family kind of should be aware of that and respect that, and do all the cooking without salt. And it's a small difficulty for the other family members to keep a bottle of salt on the table. And so just add salt when as needed and not use it while cooking. Avoiding foods like fatty meats, butter and cream, which are very high in saturated fat. And then, eat moderate amounts of food, cut down on the saturated fat, bake, broil, roast, and boil food. So this is quite challenging for us because the Kerala diet, we enjoy having the nice oily cooked food, and especially the coconut oil. I must confess that I really love things cooked in the coconut oil, but I think probably it will be better to have it boiled or roasted or baked. So if there are any questions about stroke, I'll be happy to take it now, or I'll just go to the next topic of dementia.
Yes, doctor, 1 second. Basically, I want to know about controlling the blood pressure ideal target.
Yeah.
Also, prevention of stroke in way of taking an aspirin daily, baby. Secondary prevention, maybe a baby aspirin 81 milligram.
Yeah.
As long as there is no GI bleed or a stomach ulcer. What are your recommendations?
So both are very excellent questions. So the blood pressure target, we generally say you aim for 130 over 80 or 120 over 80. That's what we recommend in Northern America. Whereas in Europe, recently, I think as recent as few weeks ago, they kind of upgraded that to 140 over 90. Okay, but India, I think we tend to go by what North America does. So I think that will be reasonable, 130 or over 180 or 140 over 90. Definitely it shouldn't be above that. Okay, so that's a good number for you to remember. And the second question was about taking a baby aspirin. And there is no evidence to recommend what we call as primary prophylaxis. If you never had a stroke or a heart attack, should you be taking a baby aspirin? Should you be taking cholesterol lowering pill even when your cholesterol is borderline? Unfortunately, we do not have evidence. And if you have had a TIA or a minor stroke or angina, by all means, you have an indication. Because if you take aspirin, you have had a TIA, the aspirin decreased the risk of a second stroke by 25%. So remember that there's nothing absolute in all this. The absolute risk reduction, it will only give you a protection of about 25%. Now, why I said, okay, you may or may not take aspirin, because taking that baby aspirin could put you at some risk for bleeding. So if you have a cut or an injury, or somebody has an ulcer, or or a diverticulitis you are not aware of, sometimes it results in really inconvenient or dangerous bleeding. So I think the jury is still out, and people have not really given like evidence-based recommendation that everybody about the age of 50 or 60 should take baby aspirin. So I think that's where we stand. But people really choose what they want to do, right? So I know cardiologist friends of mine who are taking something what we call as the poly pill. Okay, so they take a baby aspirin, they take a statin, and also they are taking metformin to lower their blood sugar. And there's no evidence for that. But I know personally, highly educated people who do that. So I don't think at this point there is any recommendation from any medical body to say that people should be taking primary prevention with baby aspirin. Okay, so we will go to the next topic, and dementia. And this is so important to talk about dementia. Usually what happens is people discuss about dementia on World Alzheimer's Day. The reality is that with advances in the healthcare and in general improvement in your living conditions, your life expectancy is going up, And this is what we call as the graying of the population. So it's very normal to have a life expectancy, above the age of 70 or 80 in many populations in the world. And the prevalence of dementia, if you take a cohort of people who are above the age of 65, so that prevalence may be something like 2 to 5% of them could be at risk or could be having mild to moderate dementia. And the increasing age, by every decade, the prevalence kind of doubles. So if you have a population who's above the age of 75, and then the prevalence may be something like 10%. Suppose you go to a retirement home where the average age of persons are like 80 or 90, it is quite possible that 30 to 50% of that population would have some form of dementia. So, so it's a really big problem. It's just age catching up with us. And what is dementia? It's a general term for loss of memory, language, problem solving, and other thinking abilities. And the next sentence is very, very important. This should be severe enough to interfere with your day-to-day functioning or daily life. So it's not uncommon as we age, the agility of our mind or your memory functions may not be as sharp as when you were 20 years of age. Or you meet an acquaintance in church, maybe you have met this person 1 year ago, and you know this person's face, and you know who he is, but unable to say the name. This is what we call as tip of the tongue phenomenon. Or you say, oh, I don't remember where I left my car keys. And this is something which all of us have, because sometimes we are not so mindful, or we are distracted by too many things on our plate, and that is not dementia. Okay, but by all means, if you think the memory is worsening, you are making mistakes when you balance your accounts at the end of the month. Your income and expenditure, you say, hey, there's a huge gap in, I have no idea where this $400 went. That may be serious if that's a recurring theme in your life. Okay. And what is Alzheimer's? Alzheimer's disease is the most common type of dementia, but all dementias are not Alzheimer's disease. This figure kind of gives you the breakup. So most common of these, the Alzheimer's disease, which is about 60 to 80% of the dementias, and it's a slowly progressive degenerative conditions which you cannot cure. Okay, you can only give supportive treatment. And a smaller percentage of people have frontotemporal dementia, where you have more of behavioral changes, which can be, sometimes very unsettling for persons. Somebody who's 70 or 80, very pious, church-going person, suddenly showing inappropriate sexual behavior, either towards his spouse or to total strangers. That just shows that your frontal lobe is the one which decides your appropriateness of behavior, your planning, your executive functions. Those are kind of impaired without actual impairment of memory. So people don't even recognize that. People don't realize this is a neurological condition, and they just think that this person has a psychiatric problem, when actually this could be just a dementia which is starting. So I had a elderly lady I took care of while I was working in India. And this lady is from a very rich family, and the children are all well settled, and they come and visit her maybe like once a month. And she's also known to be very stingy. Okay, so she has a lot of money, but she wouldn't share it with anyone. Okay, and then she would have usually a young lady who stays with her to help with the cooking or cleaning the house. And slowly this lady's behavior changed, that she became so loving to everyone. She would hug and kiss them and just give away money to everyone. Okay, and actually she was brought to me by her son, saying that this is not my mom, but everybody who was working for her was so happy with the change in behavior. And that was actually frontotemporal dementia, which she was developing. Okay, and there are other dementia, such as vascular dementia. So this is kind of small mini strokes happening in your brain, and sometimes they are so tiny that you don't even recognize that you had a small injury to the brain. And this slowly add up over many years, and you could have a vascular dementia. So you can see that there's quite a big variety of disorders. And just because you have Alzheimer's disease doesn't mean that you cannot also have vascular dementia, because you would have vascular risk factors which made you vulnerable for developing multiple strokes. So you could have a mixed dementia. How does it manifest? So the common symptoms are difficulty with everyday tasks. Simple things like making a cup of coffee becomes so challenging. You are amazed when you see your mom or your wife do a very complex recipe which has some 30 different steps to be done, and they just do it like that without even thinking. And those kind of tasks become very difficult, and it becomes a challenge. And so that difficulties with everyday tasks, handling money, I think this should alert you that something is wrong. Or they could have confusion in familiar environment. So they just go to the grocery store and around the block, and coming back to the house, they lose their way. Or difficulty with words and numbers, memory loss, or changes in mood and behavior. And this is very, very common. Sometimes you have just depression, and sometimes the depression is mistaken for dementia. So I will also briefly mention about when you say dementia, sometimes a psychiatric condition or depression is mistaken for dementia. Sometimes it's the other way around, because depression could be the first sign of dementia, and that's mistakenly just treated as depression without recognizing that this person should have a full neuropsychological evaluation to test their memory, their praxis, language, executive function. So if you tested all those domains, you would realize that he has deficiencies in multiple cognitive domains and not only in the mood or behavior. So who is affected? Each one of us are at risk. Okay, so you see that there are 50 million people worldwide who have dementia. So 1 every 3 seconds, who is developing dementia. These are figures from WHO. So so don't think that these are exaggerations by any way. And this number is going to triple by 2050, because the graying of the population, that's going to be inexorable. It's going to be progressive. So what is the cause? The most common cause, that's Alzheimer's disease. It's something where you lose cells or neurodegeneration in the brain. And there's also deposition of a protein we call amyloid. And inside the neurons, there's a protein called tau, Tau, and there are microscopic structures we call neurofibrillary tangles. So the knowledge is still incomplete. We know what's happening in the brain, but we do not know why that is happening. Okay, so knowledge is incomplete, and the advances are not fast enough to satisfy us. If one family member is affected by Alzheimer's disease, it's already too late. The only thing you can give is supportive care, But some of the breakthroughs are very, very heartening. For example, that people with Down syndrome, they have an extra copy of the chromosome 21. Each of us have 23 pairs of chromosomes in our body, the genetic material. And the chromosome 21 actually harbors the amyloid precursor protein. So I told you that amyloid is one of the proteins that get deposited in the brain in Alzheimer's disease. So interestingly, the people with Down syndrome have 3 copies of the chromosome 21. So they have an extra dose of the amyloid precursor protein, and they have early deposition of amyloid in the brain, so much so that people with Down syndrome, a lot of them are high functioning, but by the time they are 35 or 40, their brain looks like that of a 80 or 90-year-old person with Alzheimer's disease. So we do know at what is happening at the cellular level or molecular level or the synapse level, but the truth of the matter is we do not have a cure at this point in time. Okay, so what about Canada? Are we special? We are not special. So we are just like any other person in the world. So 1 in 5 Canadians have experienced caring for someone with a type of dementia, and more than 500,000 Canadians live with dementia. So this is important. And surveys have shown that 56% of Canadians are concerned about being affected by Alzheimer's disease. All the more reason for you to be aware of this condition and take steps to have a plan in place, because we never know which one of us is going to confront this situation. Okay, so what happens in the brain? On this side, this is how a normal brain looks. So this is the outside is the gray matter, inside is the white matter. And this part of the brain is called the temporal lobe. So you can compare that on the other side to a person with Alzheimer's disease. You see that the brain on this side of the slide is kind of shrunken and smaller. So you have extreme shrinkage of the cerebral cortex and severely, you have enlarged ventricles. And this structure is so vital, the temporal lobe, and this is the part of the brain which supports your memory. For example, you read a passage from, from a book, and your ability to narrate that passage. So that is what we call as, the episodic memory. And that is significantly impaired when this structure called the hippocampus becomes atrophic. Okay, so I've just put in the medical terms for this, so don't worry if you cannot follow that. So what are the diagnostic criteria? The dementia is an acquired impairment memory associated with impairment in one or more cognitive domains. Could be executive function, such as abstract thinking. Abstract thinking is something we do all the time without even thinking. For example, you say, okay, what is the similarity between a train and a motor car? Okay, so somebody who's not able to think abstractly would say that the train has wheels and the car has wheels, and that's what there's somebody who's less educated or like early dementia would be saying, but they would not be able to categorize both our modes of transportation. So that's what we mean by abstract thinking. Reasoning and judgment. Language could be impaired. Praxis is more like a complex task. So you can just put salt onto your food, but for cooking you need to plan, you have to organize all these things and then make a whole dish. So that is praxis, doing a complex motor task with a lot of learned sequences. That is affected. And then gnosis means ability to recognize objects. Okay, so you see this object and you say, okay, this looks like a square box, but not able to recognize it's a microwave. Okay, so the impairments in cognition must be severe enough to interfere with work, usual social activities, or relationship with others. Okay, so then we say that's dementia. So you can see that it really strikes at the core of what makes you a person. Okay, so that's so heartbreaking when somebody is affected by dementia. So what are the early signs and memory concerns? You could have short-term memory loss. And this stage is especially very challenging because the sufferer usually denies this. So again, coming back to what Jack was mentioning, there's a lot of stigma. People think, am I losing my mind? And you want to project a very strong face. You've been an independent, strong person. So it doesn't matter. You've been an executive, you've been a physician, or you are a priest. You are not immune to developing this. Okay, so you want to deny that, you want to conceal that, and you don't seek the help that you deserve or need. And sometimes you even hide it from the family members. Sometimes it could be just lack of awareness. It's not that the person is knowingly hiding that, or he's so socially isolated that there's nobody to really look after this person. Somebody you could have mild head traumas, fall down, but your memory is so bad that you don't even recognize that. And sometimes it could be your other medical needs are also kind of neglected. So all these could be early signs of which should raise the concern that person is developing dementia. Sometimes it creeps up on you so insidiously that the persons living in the same household may not be able to recognize. It's only your brother who visits you after 2 years suddenly recognize, this is not my sister. My sister is so different. So sometimes it creeps upon you that very close family members or acquaintances do not realize that you are changed. And unfortunately, there's no single test which will give the diagnosis. So you cannot diagnose early dementia with a CD scan. Then you have a lot of struggle with patient confidentiality. So what the family physician or the neurologist struggles with, in the early stage, what is the time when you divulge that information to the son or to the brother? Because the person should be his or her own boss, right? So can this person give consent to the doctor to share that? And sometimes there is misdiagnosis. Seeking the treatment is is something very important in the early stage, because part of the problem in Alzheimer's disease is with a neurotransmitter called acetylcholine. So there are medications which could delay the decline in memory or stabilize the memory difficulties for few weeks or months. So using that in the early early stage of the disease may be something, to consider. But remember that there is no cure. So, searching for a cure, which will only be possible in something which is, so that's why you should always get an opinion from your doctor if you're concerned you have dementia, or get a referral to a cognitive neurologist. So cognitive and behavioral neurologist. So these are available, in Toronto, Western, or St. Michael's Hospital. So you could have evaluation by a cognitive neurologist or a neuropsychologist who can assess, see which domains are impacted. And sometimes you are able to find out underlying reversible conditions such as a B12 deficiency, hypothyroidism, or sometimes it could be a brain tumor or a subdural hematoma. But these are more the exceptions than the rule. So by all means, if you have suspicion of a dementia, you deserve to be evaluated. Then the inevitable question, having had a diagnosis of dementia, you should find the right carer. Okay, you have a lot of unanswered questions about the future, getting more information, and the late stage is very heartbreaking. You have deterioration in health and well-being, and then the main concern is to keep this person safe from harm and say that they are, supported around the clock. So, even though I have put this here, writing a will and making plans, I think all of us need to have a plan in place for all these eventualities. So this is not only applicable to dementia, but this is applicable to life in general as we age and become more and more frail. Okay, so what happens in late stage of dementia? Unfortunately, this is the reality for many number of us. Okay, so the person becomes bedbound, requires around the clock care, and people were doing that in joint families. Your dad or grandfather or grandmother was bedbound. They will just, oh, my grandma is just old and frail and she's bedbound, but she has advanced Alzheimer's disease. There was never a name for that. Okay, but this was there with us all along. They'll just say, okay, she's just bedbound, she's incontinent in stool and urine, and that's Alzheimer's disease. They have loss of facial expression. They have problems with everyday activities like bathing, dressing, eating, and unable to walk or sit up without assistance. Okay, so that's kind of the reality. So do you have any more questions about dementia?
I had a question, Jack here. So you mentioned about frontotemporal dementia,
Yeah,
and it kind of made me recollect about Kluver-Bucy syndrome.
yeah,
Except here, dementia is insidiously causing the personality change, and
that's
it's
right.
not. And in media, we commonly hear about injury or trauma leading to those kind of changes. So I think that's something we don't know about. But my question was, in regards to dementia, we know that certain stimulants or caffeine is sort of, we hear that it protects against cognitive decline.
Yeah.
But there's an emerging field of medicine or pharmaceuticals which is called nootropics. And so I just wanted to hear your thoughts on nootropics, or is there any sort of, do you have any input on that? Or?
No, unfortunately, we do not have any evidence to recommend any of these. Okay, so people say we could try something like piracetam, or we could like ginkgo biloba. And so people try all these things, and for a while the virgin coconut oil was supposed to be the fad, So we are always.
I think somebody
hopeful.
wrote that in the chat box. They're asking if coconut oil is actually beneficial for.
Yeah. So I would say, spend your money on eating healthy and getting regular exercise. Probably, that's not easy. People just want a pill to be taken and that will take care of all your illnesses. Unfortunately, that's not so simple. And all these nootropics are also not, evidence proven to help with. I think that's important to understand.
But there's no harm with regards to the age-old saying of caffeine and tea will keep you sharp, and there's no harm in it, right?
Yeah. So I think that's the more important. Like caffeine, definitely everything in moderation. So I would say, having 2 or 3 cups of coffee or tea, definitely by all means. More important would be to have cognitively stimulating activities. Okay, so very interestingly, a colleague of mine, his Dr. Joe Verghese, he is a neurologist in the Albert Einstein College of Medicine in Bronx, New York. So he has done community-based studies. So they have followed a cohort of 10,000 people and saw how many of them were developing dementia. So he said that People who have more sedentary habits, like, what's your main entertainment after coming home? I watch TV for 3 hours or 4 hours. Versus somebody who, reads a book or does crossword puzzles or Sudoku, or plays Scrabble with your spouse, so those people seem to be, less prone for developing dementia. Okay. And the problem with all these kind of studies, these are what we call as statistical associations. Okay. So statistical associations are different from causality. Okay. So you cannot blame somebody and stigmatize, you watch TV for 3 hours every day for the last 10 years. What do you expect? Your brain has been shot out because of your unhealthy habits, so that is not easy, and I will briefly give an example of something we call as the NUN study. So NUN study is very interesting. It was a longitudinal study that went on for 40 or 50 years. These young ladies who joined to become nuns in their late teenage years or early 20s, they were asked to write a passage, like a motivation letter why they want to become a nun. So they went back and analyzed these letters, and all these nuns, when they became older and died, they donated their brains for autopsy and histological studies. And some of them had obvious dementia. Some of them had a full healthy life. They died at the age of 80, but they saw that on under the microscope, half of the brain was already affected by Alzheimer's pathology, but they never manifested that Alzheimer's disease. Okay, so they found this relationship between what we call as cognitive reserve. So cognitive reserve means somebody who has a high degree of brain functioning to start with. So all these nuns who had a more complex use of words or higher command of language or higher complex ideas in their motivation letter, they were more protected from the manifestation of dementia. So they did develop the pathology, but they had a lot of reserve or buffer which prevented the Alzheimer's from manifesting. So, so is it a cause or effect? We still do not know, but definitely doing more cognitively challenging activities, I think that's definitely to be recommended.
So basically, it's like that saying that the brain is a muscle, use it or lose it.
Yeah. So, so very important for us to say that when somebody is having dementia, you didn't use it, so you lost it. I don't think we should say that because we don't have the evidence for that. But I think definitely we should try to use it more. Yeah. All right. So if no more questions, then let me go to the next topic, and so that I'll give time. I think I took too much time already. So epilepsy is something which we commonly encounter. If you look at the prevalence, if you take 100 people on the street, one of them could be having epilepsy. Okay, so you wouldn't realize it. It could be a nurse or a doctor who's taking care of you in the hospital could be having epilepsy, because this is an episodic disorder. Okay, so what happens is that suddenly a part of your brain or both sides of the brain develops something we call as an electrical storm. Okay, so that storm is something, let me try to show you. This is how a normal EEG looks. And the beginning part, you see a lot of high amplitude activity. So this is like an electrical storm that causes the seizure. So epilepsy is a neurological disorder where the brain activity suddenly becomes abnormal. It's a transient condition causing seizures or periods of unusual behavior, sensations, or sometimes loss of awareness. So all of us are familiar with seizures coming with, big shaking movements, frothing at the mouth, somebody tongue bite, and urinary incontinence. And that's what we call as, generalized convulsions. But there are also different types of seizures. So anyone can develop epilepsy. It could affect both males and females of all races, ethnic backgrounds, and ages. So remember that. So this is just a cartoon to illustrate that a part of the brain could be having like a hotspot which just fires into the seizure. Okay. So this is a slide which I took from WHO. So it's a neurological condition characterized by recurrent seizures. It can affect the entire spectrum of ages, from a newborn baby to an older person. And these are brief disturbances in the brain function and abnormal electrical activity, which we can easily measure by doing the EEG. And what are the conditions which we, like quite good number of persons, we do not have any explanation why they develop seizures. But sometimes it could be sequelae of an infection you had in the past, like a small parasitic calcification, cysticercosis, remote stroke, or a head injury. In a small percentage of them, 1% of them, there could be a genetic basis, could be the first sign of a brain tumor or brain injury which you had when you were born, leaving a small scar in the brain, could result in the development of epilepsy when you become older. So I think these are all the causes of seizures, and it has a huge impact in the world. So more than 50 million people are living with epilepsy. And unfortunately, due to the population demographic, 80% of these people are living in low and middle income countries. And this is more heartbreaking because 75% of these 50 million people do not receive treatment, and there is nothing more heartbreaking than eminently treatable disorder which could improve the quality of your life, and either you are not aware that it can be treated or you do not have access. It's simply not. So it could be a lack of trained staff, it could be poor access to anti-epileptic medications. That in a huge country like India, there is no public drug plan. So it's not as if people with seizures would be eligible for medication. That's interesting. In Tamil Nadu, if you are diagnosed with epilepsy, government will give you free anti-seizure medications. Okay, but this is kind of a policy which in the public health domain you have to take that, and the private drug plan is not even available in Canada, unless you are on Ontario Works or on ODSP, then you would be eligible for a drug plan. So these are the costs of treatment gap, poverty, low prioritization for the treatment of epilepsy. So people have a lot of stigma against epilepsy, and it's not in the radar of people who make the public health policy. And if you have seizures, you are at 3 to 6 times greater risk of premature death. And this is a condition we call as SUDEP, or sudden unexpected death in epilepsy. Usually affects young people with uncontrolled seizures between the age of 20 to 50. So, so this catches people in the prime of their life, when they could be contributing to their family or to the society in general, and we lose these young lives. So somebody who's having high, uncontrolled seizures, even 2 or 3 seizures in a year, is at a high risk of dying. And the usual story is that this person just went to bed and next day morning he did not wake up. So probably he had a seizure in sleep, and that was the cause of the death. So and it just like the conditions we discussed, like depression, mental health problem, there's a lot of stigma and discrimination. So they are less successful in their family life, less successful in obtaining the education which they deserve, or a job training, or attaining employment. So all studies across developed and underdeveloped countries have shown that people with epilepsy generally have lower socioeconomic status. They have other the social success is low, chance of attaining educational success, everything is low. So you can see that big impact. And is epilepsy preventable? A lot of the conditions in the developing world, up to 25% cases worldwide, could be preventable. So what's the commonest? Preventing head injury, asking young people to wear a helmet while they're going on a motorcycle or a scooter or even the bicycle. That's the most effective way to prevent post-traumatic epilepsy. And improving the perinatal care when a baby is born, it can reduce complications suffered by the brain at the time of the birth, and that can reduce new cases of epilepsy caused by birth injury. And then when there are small children who have what we call as febrile seizures, fever-related seizures, and using drugs and other methods to lower the body temperature, that could help to prevent the febrile seizures. And then here we are coming back to the theme of preventing stroke. So just like that, if you have just like all the factors that we discussed, preventing high blood pressure, diabetes, obesity, avoiding tobacco, excessive alcohol use, this will also avoid the development of epilepsy we call as post-stroke epilepsy. Okay, and in tropical countries, you have a lot of central nervous system infection, tuberculosis meningitis, neurocysticercosis. These can produce scars in the brain that can turn out to be a focus, which spontaneously develop into seizures later in life. Okay, so that's a thing which we need to have an urgent priority. And foundations such as Bill and Melinda Gates Foundation, a lot of things for eradication of tuberculosis, malaria in the developing world, and that's very, very commendable. And then elimination of parasites in the environment, and education on how to avoid infection can be effective ways to reduce epilepsy worldwide. So in this pandemic, we realize how interconnected we are. We say something happened in Africa or something happening in Tamil Nadu has no consequence to me. But you realize how even a tiny virus starting in a very remote corner of the world, such as Wuhan, in no time can affect the whole world. Okay, so I think it's more and more important that we are aware of what is affecting our brothers and sisters all over the world. So what is the solution? Epilepsy can be treated with inexpensive and effective anti-epileptic medication. So 70 to 80% of people with epilepsy, just with medication, a single medication, they have normal life, not different from any other person. So you wouldn't even recognize this person has epilepsy, and they can lead normal life. 20% of them, whatever medications we try, they are very resistant to treatment. So then usually they are referred to an epilepsy specialist, like our team in Hamilton. And we do have various options for them, trying newer anti-seizure medications in combination. We have stimulators like a pacemaker we call vagal nerve stimulator, or we could even offer them brain surgery. And that's which we are specialized in. We record the brain activity 24/7 for 7 to 14 days and try to pinpoint if the seizures are arising from a small spot in the brain and whether that can be safely operated. Okay, so there are a lot of treatment options. And this is the last two slides. I'll just touch upon these just to show you the social and economic impact. It accounts for 0.5% of the global burden of disease. And this is a measure that combines the years of life lost due to premature mortality and a time that is lived in less than full health. So that means this person is less productive and doesn't contribute to the economy. So this has significant economic implications in terms of healthcare needs, and it drains the resources. Somebody is not taking the medications regularly. He may be having a big seizure, brought to the emergency room, perfectly preventable, and that takes the time, the resources away from somebody who's come with an accident or a heart attack, and that much time is not devoted to those people. And so you have risk of premature death, lost work productivity. So a lot of impact to the society and economy. And this varies significantly depending on the duration and severity of the condition, response to treatment, and the healthcare setting. And this produces a lot of out-of-pocket costs and productivity loss to the patient and the family in general. And I was really struck by the COVID pandemic. A lot of my patients are unable to come physically to the clinic because the clinics were closed. They were only accepting urgent people, and we were doing a lot of clinic visits through the Ontario Telemedicine or Telehealth Network. And the person was saying, "So doc, it's so nice that you're coming into my home," and because it was always a question, he doesn't have a driver's license. So a family member or a friend has to drive him to the hospital, and the parking was costing him $12. Somebody living on a budget of, he's on Ontario disability, so he gets $700 a month, and that $12 is a big burden on him. And he says, my friend has to drive around for 15 minutes before he finds a parking spot. So they are so thankful to get that appointment over the telemedicine. We are able to give them the care that they deserve, and these are small things that really adds up. Out-of-pocket costs, loss of productivity, and to bring this person into the clinic, the other person had to lose half day of work or wages. Okay, so just imagine the snowballing effect. And economic study from India estimated that public financing of the first and second line seizure medications and medical costs, this was alleviating the financial burden from epilepsy. And ultimately, that's cost effective for the society in general. So, so there should be a decision at the policy making level. We give this medication free of cost to these people so that they don't have uncontrolled seizures leading to premature death or ER visits. So, and this is the last slide, know that epilepsy and human rights, with people with epilepsy can experience reduced access to educational opportunities, workplace. One of my patients, he was a welder at the National Steel Car, that's one of the factories in Hamilton. And this guy was doing welding, wearing all these protective clothes. He had a seizure and he fell into the molten steel. So that was, fortunately, because of protective clothing, he didn't get severely burned. And then 3 months later, he lost his job. Okay. So I asked him, hey, I think there's a question of discrimination here. They can't fire you because you had a seizure. So he said, no, doc, it's not me. They just fired 100 people. So, and I was part of that 100 people who got laid off. But then I told him, it's not surprising. You will probably be one of the first on the list who should go. Okay. So that's unfortunately the reality. And there's a lot of discrimination and stigma. Remember, the man went on moon in 1969. Okay. So people could put man on the moon, but in the United Kingdom, the so-called developed country, or in the US, the laws were in place which permitted the annulment of a marriage on grounds of epilepsy. Okay. And in US, until the 1970s, it was legal to deny people with seizures access to restaurants, theaters, recreational centers, and other public buildings. So you need a lot of awareness and advocacy for these people to avoid this stigma and discrimination. Okay. So these are, like what do you do when you see somebody who has a seizure? Stay with the person, start timing the seizure. Seizure is going on for more than 5 minutes, call 911. Keep the person safe. Don't put anything into the person's mouth. People wrongly think holding them onto metal or a key will abort the seizure. Doesn't happen. Keep the person safe. Move from harmful objects like sharp objects which could hurt the person during the seizure. Turn the person onto their side if they're not awake. Do not block the airway. If there is tight clothing or a tie, just loosen that and do not restrain. Do not try to give CPR, because during seizure, the breathing may appear shallow, but usually they recover in about 5 minutes. So if seizure lasts longer than 5 minutes, if you have repeated seizures, if the person is turning blue, or seizures are occurring when the person is in the swimming pool or in the water, or due to the seizure, person has suffered lacerations, scalp wounds, and they are not recovering within 5 to 10 minutes, call 911. Okay, so I think, or the person is pregnant or sick. So that's very important. But otherwise, if somebody has a medical bracelet saying that I have seizures, I have uncontrolled seizures, usually wait for 5 to 10 minutes, the person will recover back to his or her baseline. So it's important that you just people around the patient should be made calm. And sometimes there's a lot of stigma that people immediately say, oh, he was drunk or he must be on drugs. That's why he's having that seizure. So it's important to stay by that person, see that he or she is back to baseline, or get him to the home or his somebody who, if there's an address, call that person rather than kind of abandon that person on the road. Okay, so you could learn about these first aid if you're more interested. I'll be very happy to share these resources with you and comfort the person, speak calmly, and you could offer to call a taxi or another person or a family member to ensure that the person gets home safely. Okay, knowing what to do is important, and so they cannot swallow his or her own tongue. Do not hold the person down, and you don't give mouth-to-mouth resuscitation or CPR, and don't give them any food or water until he or she is fully alert. Okay, so what can we do for seizures? So this is what is available from the WHO website. You need a lot of public education. They need to learn more about epilepsy. You involve people with epilepsy, with their families and communities. Education of people around that person or patient, very important, and encourage them to seek treatment and make follow-up appointments with their doctor, very important. Okay, so that's what we can do in the public domain and with the patient. And we also need to lobby the healthcare workers, the policymakers to, for example, because epilepsy is not anybody's fault. So the least you could do is make the seizure medications, which are like cheap enough to be available free of cost to these people, because they already do not, they are underemployed or unemployed. Okay. And then you could ensure access to the treatment, so ensure access to epilepsy treatment. And there's a nice initiative in Ontario. It's called Project ECHO, ECHO. So ECHO is a free online platform which teaches family physicians and community neurologists to give better care to patients with epilepsy. So it's a very nice initiative, and the province has put in a lot of money to do that, and educating and training the healthcare workers and providers. I think that would be the important. I thank you for your attention, and I'll be happy to answer questions if you have them. Thanks.
I just want to start off by saying thank you for a very informative session. And additionally, you have a your presentation is very pleasing, and it's definitely captivating the audience. So thank you for that. So I have a couple of addendums, and I'm hoping that you would elaborate on these. The number one is I'm going back to stroke and symptoms or clinical symptoms of stroke. So one thing I've noticed is that among my patients itself, there have been several times when stroke symptoms may have been missed due to an pre-existing condition such as Bell's palsy or trigeminal neuralgia, which also have very similar symptoms, and they mimic a stroke symptom. So if the patient had already been diagnosed with any one of those conditions, then the physician may be saying, well, you already diagnosed with this.
Yeah.
So at some point, it may have been missed. That is something that I'm hoping you could speak on. And the other, a few of, and sometimes it could be a benign tumor of the middle ear.
Sorry, I think I lost that last part.
Tumors of the middle ear.
Yeah.
Particularly, I was thinking of paraganglioma or gliomas, where the patient would have or they would feel loss of balance or a lot of symptoms again, which mimic symptoms. So if you could speak on that and teach us and inform us as to how to differentiate or how to go about it.
So I think that's a very, very important question. I wasn't sure whether I should address those because this is like a preliminary introduction to stroke. So I think that is more in the domain of a missed diagnosis, or a incorrect diagnosis where the person has a new stroke, but due to a pre-existing condition, they falsely or wrongly attribute it to the pre-existing condition, and that's a disservice to the person. So that's like a error, a medical error, and that's very common. And I could give you countless examples of what we call as stroke mimics or seizure mimics. So it's not uncommon for people with vertigo. It could be just due to a peripheral benign positional vertigo, and they're concerned, that could be a stroke, or somebody who's having a pre-existing benign positional vertigo, a middle ear problem, and developing a new brainstem stroke, and they falsely attribute it to. So it can be an error of omission as well as commission. Okay, yep. Over diagnosing stroke or missing stroke. I think when there is doubt, I would say don't lose time. Go to the ER. ER doctors are not immune to making mistakes. So even in a tertiary center, the error rate can be 15 to 20%. So that's something we have to be alert, and that's why more and more awareness in the population and the public and doctors, it's very important so that you can advocate for yourself. You have that feeling, no, this is different from my positional vertigo. This is something very new. I have additional problems like slurring of speech. Now I have also mild numbness in my arm. So the company that it keeps also gives you a clue that there's something more sinister than the pre-existing condition.
Right, thank you. And if I could just add one more thing. So this is just for everyone, including myself. I have a very close colleague and a friend of mine who was, at the time, she was 41 years old. She had a stroke, and let me just go into it. Yeah. For the last 10 years of her life, since she was 30 years old, she had been an avid marathon runner.
Okay.
So annually, she would run about 11 to 12 marathons that were, around the GTA. Everything that went from Princess Margaret to Sick Kids and St. Michael's, every one of them, the Scotia Marathon, she took part in every single one of them.
Yeah.
And she was driving, she was on the DVP, going to work. She had her first patient scheduled for 9. She was on the DVP. She felt something coming on. It's the DVP. So she put her 4 flashers on and she called 911. And they actually had to come helicopter out of there, just because of the traffic. But so essentially what I'm saying is, none of us are invincible to stroke.
Correct.
So we all have a responsibility to keep an eye on our own health and the ones who are around us. It doesn't matter how fit, and it doesn't matter how well of a lifestyle you've been living.
Yeah.
None of us are invisible to stroke. So we should keep an eye on ourselves.
Very, very important. I fully agree. Okay, so if there are no more questions, then I thank you once again for visiting. Have a fruitful session. Thank you.
Thank you, Dr. Joseph. I think there was one more question in the chat.
Sure.
From Deepa Auntie. Can epilepsy be completely cured with medication?
Yeah. So I think that's a very good question. 80% of the people, they are on just single anti-seizure medication, and they are completely controlled. Now, whether by cure you mean that remission without medication, okay? So only about 30% of them go into remission without medication. So usually we wait for 3 or 5 years when the seizures are fully controlled. And oftentimes we look at other prognostic factors. For example, if the MRI scan of the brain is completely normal, we do the EEG, it doesn't show any abnormal blips like we call as spikes or sharp waves. So if the EEG is normal, the MRI is normal, no seizures for 3 years, by all means, we could try decreasing the medication. So generally what I do is slowly taper and stop the medication over the next 6 months or so. And then that's what we do. And that could happen in about 30%. But to answer your question simply, 80% of the people would have complete control of their seizures, and you wouldn't even know that they are on medical treatment. And nowadays we have so safe medications that it's still compatible with having a normal, healthy pregnancy, having a baby. And, even the anti-seizure medications, the newer anti-seizure medication, the risk of teratogenicity for the unborn baby to get any major malformation due to the medications is in the order of 2 to 3%. And that is not different from a young lady who's not on any medications. Okay, so somebody who's not taking medication still have a risk of a baby with malformation of 1 to 2%. And with epilepsy medications, it's only increased to 2 to 3%. So again, very important that they take folic acid supplementation and one of the safer anti-seizure medications. So very, very compatible with normal life and life expectancy and success in life.
Thank you, Dr. Joseph. So again, we're on behalf of everyone here. We're eternally thankful and grateful that you gave such a wonderful presentation and really helped us, the older adults, especially the community, the Malayali community, the older adults here, take one step closer to dispelling a lot of the stigma and with awareness. And I know that you're very busy, and despite that, you took a lot of you wholeheartedly took this time out of your day to present, and you passionately answered all of our questions and patiently heard all of our questions. And so we once again, we're very grateful, and we thank you so much.
Thank you.
Bye-bye. And we appreciate you offered to share the presentation or the resources.
Yeah, I can send it to Punaran, and then I will send the PDF to him.
Okay. So thank you so much, Doctor.
Bye.
And thank you to Reverend Father Pius Malier Achin for patiently waiting with us. I know that Achin was expecting to be attending to another meeting shortly after he said 12:15, but we're so grateful and thankful to you, Achin, for waiting patiently for so long. And so I would like to invite our next speaker, Reverend Father Pius Malier Belian Achin, who recently moved to Indianapolis from Toronto. Previously, for 3.5 years, he was the chaplain at Sacred Heart Kerala Roman Catholic community in Toronto. I think many of you would remember him from the Ecumenicals. And currently, he's now at St. Joseph's Church in Indianapolis, where he's also enrolled in the doctoral program for a PhD in the School of Social Work at Indiana University in USA. And Achin was ordained in the year of 2011. He's originally from the Diocese of Koilan, and he served as Assistant Director and Director of Koilan Social Service Society in Kollam. And he was also able to initiate 2 homes at Kollam, Anjanam Children's Home, which is an orphanage, and QSS Shelter Home for the rehabilitation of domestic violence victims. And so Achan has a presentation that he would like to share with us regarding our theme and topic of today, which is titled Hopeful Living and Changing Lives. And I will just adjust the meeting settings so that Achan can, I believe Achan has a PowerPoint presentation that he would like to share. It is my honor to invite our next speaker for today, Reverend Father Pius Malia Balian Achan.
Thank you, Jack. I appreciate the effort that is being taken by the St. Ignatious Knanaya Jacobite Church. And I had a good time with them, like at least thrice a year, joining for the Ecumenical Council for different programs. And last time we were fortunate to get the first prize for the Bible quiz competition from our church. And I really thank all the coordinators who coordinate that work in Toronto. Giving hope and changing lives is the topic that I would like to talk today. So I was asked to talk in Malayalam, so I'm just switching completely from English from Father, because Dr. Joseph Cherian was giving us a wonderful topic, and I really appreciate his effort for such a wonderful, informative talk on so many practical things that which we need to know about the stroke and dementia, epilepsy. So giving hope. അപ്പം ഡോക്ടർ പറഞ്ഞ ഒരു കാര്യത്തിൽ തന്നെ ഞാൻ തുടങ്ങുകയാണ്. നമുക്ക് ഈ രോഗികൾ വരുമ്പോഴത്തേക്ക് പിന്നെ അങ്ങ് നമ്മൾ സ്റ്റിഗ്മ കൊടുക്കുകയാണ്. അയാള് കോവിഡ് ടെസ്റ്റ് പോസിറ്റീവ് രോഗിയാണ്, ഇനി അങ്ങോട്ട് പോകണ്ട. എന്നെ ഇന്ന് രാവിലെ എൻ്റെ ഒരു സുഹൃത്ത് വിളിച്ചിട്ട് പറഞ്ഞു, അമ്മയ്ക്കും അപ്പനും കോവിഡായി, പിന്നെ അവരുടെ ഒരു ആന്റിക്കും കോവിഡായി, അപ്പൊ ഇനി ഞങ്ങൾ അങ്ങോട്ട് പോകണ്ടെന്നാണ്. ഞാൻ പറഞ്ഞു അങ്ങനല്ല, നിങ്ങൾ പോകുന്നത് വിത്ത് ഓൾ ദ മെഷേഴ്സ് ഇല്ലേ, നമ്മള് പ്രൊട്ടക്റ്റീവ് മെഷേഴ്സ് എടുത്തിട്ട് നിങ്ങൾ പോവുക എന്ന് പറഞ്ഞ് അവരെ കംപ്ലീറ്റ്ലി അവോയ്ഡ് ചെയ്യരുത് എന്ന് പറഞ്ഞു. ഞാൻ കഴിഞ്ഞ ദിവസം ഒരു ലേഖനം വായിച്ചു. ആ ലേഖനത്തിന്റെ തലക്കെട്ട് ഇപ്രകാരമാണ്: ദൈവം ചുംബിച്ച മുഖപ്പാടുകൾ എന്നാണ്. എന്താണ് ദൈവം ചുംബിച്ച മുഖപ്പാടുകൾ എന്നൊക്കെ വായിച്ചു വന്നപ്പോഴത്തേക്ക് എനിക്ക് മനസ്സിലായി, എൻ്റെ കൂടെ 2001 മുതൽ 4 വരെ ഡിഗ്രിക്ക് പഠിച്ച എൻ്റെ ഒരു സുഹൃത്തിനെ പറ്റി വേറൊരു സുഹൃത്ത് എഴുതിയ ഒരു ലേഖനമാണത്. ഇപ്പം വേറൊന്നുമല്ല, 2004 ഞങ്ങൾ പഠിച്ചു പുറത്തിറങ്ങി, പിന്നീട് ഞങ്ങൾ വലിയ കോണ്ടാക്ട് ഒന്നും ഇല്ലായിരുന്നു. പക്ഷെ 2006 ഈ സുഹൃത്തിന് ക്യാൻസർ വന്നു. അപ്പൊ ഈ 2006 മുതൽ 2020 വരെ 14 വർഷം നീണ്ടു നിന്ന വലിയൊരു പോരാട്ടത്തിൽ, വലിയൊരു അതിജീവനത്തിലൂടെ ഈ എൻ്റെ സുഹൃത്ത് കടന്നു പോവുകയായിരുന്നു. അപ്പൊ അവന്റെ മുഖത്ത് ഒരു പാടുണ്ട്. ആ ഒരു പാട് ഒഴിച്ച് ബാക്കിയെല്ലാം നോർമലാണ്. ഇപ്പോൾ അവനൊരു സർക്കാർ ഉദ്യോഗസ്ഥനാണ്, ഭാര്യയും 2 മക്കളുണ്ട്, വളരെ വെൽ സെറ്റിൽഡ് ആണ്. ഇപ്പൊ എന്താണ് അവനെ ജീവിക്കുവാൻ പ്രേരിപ്പിച്ചത്, ഈ ക്യാൻസറിനോട് പൊരുതി ജീവിക്കുവാൻ പ്രേരിപ്പിച്ചതെന്ന് ചോദിച്ചാൽ അവൻ പറയുന്നത് ആ ഒരു കാര്യമാണ് ഞാൻ ഇന്ന് നിങ്ങളുമായിട്ട് പങ്കിടുവാനായിട്ട് ആഗ്രഹിക്കുന്നത്. നമ്മളെല്ലാവരും ഒരു പ്രത്യാശയുടെ സുവിശേഷം പങ്കുവെക്കേണ്ടവരാണ്. കാരണം നമ്മള് ഒരു പ്രതീക്ഷ കൊടുക്കണം. കാരണം ഗിവിങ് ഹോപ്പ് എന്ന് പറയുന്നത് ഇറ്റ് ഇസ് നോട്ട് ദാറ്റ് ഈസി. കാരണം ഒരു മനുഷ്യന്റെ ജീവിതത്തെ തന്നെ മാറ്റിമറിക്കുവാനായിട്ട് ചിലപ്പോൾ നിങ്ങളുടെ ഒരു വാക്ക്, ഒരു വചനം, അത് മതിയാവും. 2 ബേസിക് പ്രിൻസിപ്പിൾസിനെ പറ്റി ഒന്ന് മനസ്സിലാകും. നമുക്കെല്ലാം വിശ്വാസമുണ്ട്. കർത്താവിലുള്ള വിശ്വാസത്തെ പറ്റി യോഹന്നാന്റെ സുവിശേഷം 7-ാം അധ്യായം 38-ാമത്തെ വാക്യം പറയുന്നത്, എന്നിൽ വിശ്വസിക്കുന്നവന്റെ ഹൃദയത്തിൽ നിന്ന് വിശുദ്ധ ലിഖിതങ്ങൾ പ്രസ്താവിക്കുന്നത് പോലെ ജീവജലത്തിന്റെ അരുവികൾ ഒഴുകുമെന്നാണ്. അപ്പൊ ആ ജീവജലത്തിന്റെ അരുവി, നമ്മൾ ജീവനുള്ളവരായി മാറുന്നത് കർത്താവിൽ വിശ്വസിക്കുമ്പോഴാണ്. പ്രിൻസിപ്പിൾ ഓഫ് ഓപ്റ്റിമിസം എന്ന് പറയുന്നത് നമ്മളെ ഈ പോസിറ്റീവായിട്ട് ഒരു നെഗറ്റീവ് എലമെന്റിലൂടെ നമ്മൾ ഇന്ന് ഒരു വലിയ ക്രൈസിസിലൂടെ കടന്നു പോകുമ്പോൾ നമുക്ക് അതിനെ ഒരു പോസിറ്റീവ് അപ്രോച്ചിൽ എങ്ങനെ കാണാനായിട്ട്, കാരണം നമുക്കൊരു പെസിമിസ്റ്റിക് ആയിട്ട് ചിന്തിക്കാൻ വളരെ എളുപ്പമാണ്, നെഗറ്റീവായിട്ട് ചിന്തിക്കാൻ വളരെ എളുപ്പമാണ്. പക്ഷെ ആ ഒരു ക്രൈസിസിനെ, ആ ഒരു പ്രതിസന്ധിയെ, ആ ഒരു അൻസൈറ്റിയെ, ആ ഒരു ഭയപ്പാടിനെ, ആ ഒരു മരണത്തിന് മുഖത്തിൽ നിന്നുള്ള നമ്മുടെ ആ നിലവിളിയെ എങ്ങനെ പോസിറ്റീവ് ആക്കി മാറ്റുവാൻ പറ്റുമെന്നാണ് ഈ പ്രിൻസിപ്പിൾ പഠിപ്പിക്കുന്നത്. ഇപ്പൊ പോസിറ്റീവ് തിങ്കിങ് എന്നതിലുപരി പോസിറ്റീവ് ഡൂയിങ് എന്നുള്ള ഒരു കോൺസെപ്റ്റ് ആണ് ഈ പ്രിൻസിപ്പിൾ ഓഫ് ഓപ്റ്റിമിസം നമ്മുടെ മുമ്പിലേക്ക് അവതരിപ്പിക്കുന്നത്. കുറച്ച് നമ്മുടെ ഈ ഒരു കാലഘട്ടത്തെ നമുക്ക് എങ്ങനെ മാനേജ് ചെയ്യാം, നമ്മുടെ സ്ട്രെസ് എങ്ങനെ മാനേജ് ചെയ്യാം, അല്ലെ നമ്മുടെ ജീവിതത്തിലെ വർക്ക് പ്രഷേഴ്സ്, നമ്മുടെ കുട്ടികളുടെ ഫാമിലി കുടുംബ ജീവിതത്തിലുള്ള പ്രഷേഴ്സിനെയൊക്കെ എങ്ങനെ കോപ്പപ്പ് ചെയ്യാം എന്നുള്ള ഒരു 4 കാര്യങ്ങളാണ്, കൊച്ചു കാര്യങ്ങളാണ് ഞാൻ അതിനകത്ത് അവതരിപ്പിക്കുന്നത്. നോ ദൈ സെൽഫ് എന്ന് പറഞ്ഞാൽ ഗ്രീക്ക് ഏൻഷ്യൻ ഫിലോസഫേഴ്സ് സോക്രട്ടീസ്, പ്ലേറ്റോ, അരിസ്റ്റോട്ടിൽ. അപ്പൊ അതിൽ സോക്രട്ടീസ് ആണ് നോ ദൈ സെൽഫ് എന്ന് പറയുന്ന ആ ഒരു കോൺസെപ്റ്റ് അവതരിപ്പിച്ചത്. നീ നിന്നെ തന്നെ അറിയുക. കാരണം നമ്മൾ പലപ്പോഴും ബാക്കിയുള്ളവരെ പറ്റി അറിയുവാനായിട്ട് ആഗ്രഹിക്കുന്നവരാണ്. കാരണം നമ്മൾ ഒത്തിരി കാര്യങ്ങളൊക്കെ മനസ്സിലാക്കുവാനും അവർക്ക് എങ്ങനെ പോകുന്നു, എന്തു പറ്റി, അവർക്ക് എന്താണെന്നൊക്കെ ഉള്ള ഒരുപാട് കാര്യം. വി ആർ വറീഡ് സോ മെനി തിങ്സ് അബൌട്ട് അതേഴ്സ് ആൻഡ് നമ്മുടെ കാര്യത്തിലേക്ക് ഞാൻ ആരാണ്, എന്റെ ഐഡന്റിറ്റി എന്താണ്, ഞാൻ എന്താണ് എന്നൊക്കെ ഒന്ന് മനസ്സിലാക്കുവാനായിട്ടുള്ള ആ ഒരു ആക്ഷൻ ഓറിയന്റഡ് പ്രിൻസിപ്പിൾ ആണ് നോ ദൈ സെൽഫ് എന്ന് പറയുന്നത്. പിന്നെ പറയുന്നത് മൈൻഡ് കൺട്രോൾ, മനസ്സിനെ നമ്മൾ നിയന്ത്രിക്കുവാൻ. എനിക്കറിയാം ഇത് വളരെ വളരെ പ്രയാസമുള്ള ഒരു കാര്യമാണ്. ഇന്ന് ഡോക്ടർ അവതരിപ്പിച്ച ആ കാര്യങ്ങൾ ഡിമെൻഷ്യയിലൂടെയൊക്കെ അവരോടൊക്കെ നമുക്ക് എന്ത് പറയാൻ സാധിക്കും? നമുക്ക് ചെയ്യാൻ പറ്റുന്ന കുറച്ച് കൊച്ചു കാര്യങ്ങൾ ഇതിനകത്ത് നമ്മുടെ തന്നെ മനസ്സിനെ എങ്ങനെ ആരോഗ്യപരമാക്കി മാറ്റാം. അതൊന്ന് പ്രാർത്ഥന വഴിയാണ്. പ്രാർത്ഥനയിലൂടെയാണ് നമ്മൾ ദൈവവുമായിട്ടൊരു നല്ല ബന്ധം സ്ഥാപിക്കുന്നത്. പിന്നെ വചനത്തിലൂടെ, വചനം എന്ന് പറയുന്നത് വചനം വായിക്കുന്നത് മാത്രമല്ല, ഇന്ന് നമ്മളെല്ലാവരും എക്സസൈസ് ചെയ്യേണ്ട ഒരു പ്രധാനപ്പെട്ട കാര്യം വചനം എഴുതുക. എത്ര പ്രാവശ്യം എഴുതാവോ വചനം എഴുതി പ്രാർത്ഥിക്കുക. അതൊരു ഏറ്റവും വളരെ ബ്യൂട്ടിഫുൾ ആയിട്ടുള്ള ഒരു പ്രെയർ എക്സസൈസ്, ഒരു പ്രാർത്ഥന എക്സസൈസ് ആയിട്ടാണ് എൻ്റെ ജീവിതത്തെ എനിക്ക് വ്യക്തിപരമായിട്ട് ഞാൻ അനുഭവിച്ചത്. ആ അനുഭവിച്ചതിന്റെ ഒരു ഫലമാണ് എനിക്കിന്ന് ഡോക്ടറൽ പ്രോഗ്രാമിന് ഇവിടെ ഒരു അഡ്മിഷൻ കിട്ടിയത്. കാരണം ഈ ഇന്ത്യാന സ്റ്റേറ്റിൽ തന്നെ ഏക PhD ഉള്ള ഒരു യൂണിവേഴ്സിറ്റിയാണ് ഇത്. സീറ്റേ ഉണ്ടായിരുന്നുള്ളൂ. ഇപ്പൊ വലിയൊരു കോമ്പറ്റേറ്റീവ് വേൾഡിൽ നിന്നാണ് ഞാൻ ടൊറന്റോയിൽ നിന്ന് ഇങ്ങനെ 4-5 യൂണിവേഴ്സിറ്റികൾക്ക് എഴുതി തീസിസ് എഴുതി, അല്ലെങ്കിൽ അവരുടെ എക്സാമിനേഷൻസ് ഒക്കെ പാസ്സായി. അങ്ങനെ സെൽഫ് അസസ്മെന്റ് ടെസ്റ്റുകൾ ഉണ്ടായിരുന്നു. എനിക്ക് ഐ ഹാഡ് ടു ഡു ടോഫിൽ ടെസ്റ്റ് ചെയ്യണമായിരുന്നു. അപ്പൊ ഇതെല്ലാം ചെയ്യുമ്പോഴെല്ലാം എന്നെ പ്രാർത്ഥിച്ചപ്പം കിട്ടിയ ഒരു വചനം, ആ വചനം 1000 പ്രാവശ്യം എഴുതുകയാണെങ്കിൽ എനിക്ക് ഈ 5 യൂണിവേഴ്സിറ്റിയിൽ ഒരു യൂണിവേഴ്സിറ്റിയിൽ അഡ്മിഷൻ ഉറപ്പാണ് എന്ന ഒരു ചിന്ത എങ്ങനെയോ എന്നെ ഇൻസ്പയർ ചെയ്തു. അതിനുവേണ്ടി ഞാൻ പ്രാർത്ഥിക്കാൻ തുടങ്ങി. അങ്ങനെ വചനം എഴുതി 500 പ്രാവശ്യം എഴുതിയപ്പം തന്നെ എനിക്ക് ഈ യൂണിവേഴ്സിറ്റിയിൽ അഡ്മിഷൻ കിട്ടി എന്നുള്ളതാണ് സത്യം. അപ്പോ പിന്നീട് മൂന്നാമത്, ദൈവഹിതം ആരായാനായിട്ട് നമുക്ക് കൗൺസിലിംഗ് ആവശ്യമാണ്. കാരണം നമ്മൾ സാധാരണ നമുക്ക് ഫിസിക്കൽ എന്തെങ്കിലും പ്രശ്നമുണ്ട്, ശാരീരികമായിട്ടുള്ള പ്രശ്നങ്ങളുണ്ടെങ്കിൽ നമ്മൾ ഉടനെ ഡോക്ടറിനെ വിളിക്കും, ഡോക്ടറിനെ പോയി കാണും, അപ്പോയിന്റ്മെന്റ് എടുക്കും, നമ്മൾ മരുന്ന് കഴിക്കും. പക്ഷെ നമ്മുടെ ഒരു സ്പിരിച്വൽ ആയിട്ടുള്ള നമ്മളെ സോൾ എന്ന് പറയുന്ന ആ ഒരു ഘടകത്തെ നമ്മൾ പലപ്പോഴും അതിനെപ്പറ്റി നമ്മൾ വലിയ ചിന്ത കൊടുക്കാറില്ല. കൗൺസിലിംഗിൽ ഏറ്റവും കൂടുതൽ ശ്രദ്ധ കേന്ദ്രീകരിക്കുകയാണെങ്കിൽ, നിങ്ങൾക്ക് നല്ലൊരു സ്പിരിച്വൽ കൗൺസിലർ ഉണ്ടെങ്കിൽ, ഒരു സ്പിരിച്വൽ ഡയറക്ടർ ഉണ്ടെങ്കിൽ, നിങ്ങളുടെ തന്നെ ആത്മീയമായിട്ടുള്ള കാര്യങ്ങളെപ്പറ്റി, നിങ്ങളുടെ ആത്മാവിനെ ബാധിക്കുന്ന കാര്യങ്ങളെപ്പറ്റി, നമ്മൾ ശാരീരികമായിട്ടുള്ള കാര്യങ്ങൾ ഒരു ഡോക്ടർ ഉണ്ടെങ്കിൽ, നിങ്ങളെ ആത്മാവിനെ ബാധിക്കുന്ന കാര്യങ്ങൾക്ക് വേണ്ടി ഒരു ഡോക്ടറിനെ, ഒരു സ്പിരിച്വൽ കൗൺസിലറിനെ നിങ്ങൾ തിരഞ്ഞെടുക്കുക. ഹെൽത്ത് മാനേജ്മെന്റ് മൂന്നാമത്, നല്ല ഹെൽത്ത് ഹാബിറ്റ്സിനെ പറ്റിയൊക്കെ ഡോക്ടർ ഇന്ന് പങ്കുവച്ചു. മുമ്പ് പല സെഷൻസിലൂടെയൊക്കെ നമ്മൾ അത് അവതരിപ്പിച്ചു. ഈ കഴിഞ്ഞ ദിവസം ഞാൻ കേട്ട ഒരു ആവി പിടിക്കുന്നത് വളരെ സിമ്പിൾ ആയിട്ട് തോന്നി. പക്ഷെ എനിക്ക് തോന്നി എല്ലാ ദിവസവും രാവിലെയും രാത്രിയും 2 പ്രാവശ്യമെങ്കിലും ഒന്ന് ഈ സമയത്ത്, ഈ കോവിഡ് കഴിയുന്ന കാലഘട്ടമെങ്കിലും നമ്മൾ ആ ആവി പിടിക്കുന്നത് നല്ലതാണ്. കാരണം ഈ ആവി പിടിക്കുമ്പം സംഭവിക്കുന്ന പാരനൈസൽ സൈനസിൽ ഉള്ള, നമ്മുടെ മൂക്കിലെ പാരനൈസൽ സൈനസിലുള്ള ജേംസിനെ വരെ അത് പുറത്ത് കൊണ്ടുവരും. കാരണം നമ്മൾ ചൂടുവെള്ളം കുടിക്കുമ്പോൾ നമ്മുടെ ത്രോട്ട് മാത്രമാണ് ക്ലിയർ ആകുന്നത്. അപ്പൊ ആവി പിടിക്കുന്ന വളരെ സിമ്പിൾ ആയിട്ടുള്ള ഒരു ഹെൽത്ത് ടിപ്പാണ്. നമ്മളെല്ലാവരും പ്രാവർത്തികമാക്കും. കുറച്ചുകൂടെ അത് ഒന്ന് സീരിയസ് ആയിട്ട് എടുക്കുന്നത് നല്ലതാണെന്ന് എനിക്ക് തോന്നി. സപ്പോർട്ട് ഗ്രൂപ്പ്സ്, നമുക്ക് കുറച്ച് പ്രാർത്ഥനാ ഗ്രൂപ്പുകൾ ഉണ്ടാകുക, ഇതേപോലുള്ള അസോസിയേഷൻസ് ഉണ്ടാകുക, നമ്മുടെ തന്നെ ഇടവകയുടെ കൂട്ടായ്മയുടെ നേതൃത്വത്തിലുള്ള സപ്പോർട്ട് ഗ്രൂപ്പുകളുടെ വലിയൊരു പ്രസൻസ് നമുക്ക് അത്യാവശ്യമാണ്. ഇഫ് യു ആർ നോട്ട് ഇൻവോൾവ്, നമ്മൾ ഏതെങ്കിലും ഇതിന്റെ ഭാഗമായിട്ടില്ലെങ്കിൽ, try to get involved into those support groups which can really help you out. പിന്നെ പറയുന്നത്, when the whole world says give up, നിർത്തു എന്ന് ലോകം മുഴുവൻ പറഞ്ഞാലും പ്രതീക്ഷ അല്ലെങ്കിൽ പ്രത്യാശയുടെ സുവിശേഷം നമ്മളോട് മന്ത്രിക്കുന്നത് ഒരു പ്രാവശ്യം കൂടെ നീ ട്രൈ ചെയ്യും, ഒരു പ്രാവശ്യം കൂടെ നീ പരിശ്രമിക്കൂ എന്ന ആ വലിയൊരു പ്രതീക്ഷ നമ്മുടെ മനസ്സിലുണ്ടാകും. സെൽഫ് കെയർ നമ്മൾ ഈ 5 ആസ്പെക്റ്റിൽ ഒന്ന് കാണുന്നത് നല്ലതാണ്. നമ്മുടെ തന്നെ വ്യക്തിപരമായിട്ടുള്ള കെയർ, അത് ഫിസിക്കൽ കെയർ ആകാം, ഞാൻ നേരത്തെ പറഞ്ഞതുപോലെ സ്പിരിച്വൽ കെയർ നമ്മൾ കൊടുക്കേണ്ടതുണ്ട്, മെന്റൽ കെയർ കൊടുക്കേണ്ടതുണ്ട്, വൈകാരികമായിട്ടുള്ള ചില ആവശ്യം, ചിലപ്പം വൈകാരികമായിട്ട് നമ്മൾ പെട്ടെന്ന് പൊട്ടിത്തെറിക്കുന്ന ഒരു സ്വഭാവക്കാരനാണെങ്കിൽ ആ ഒരു കെയർ ആ വ്യക്തിക്ക് ആവശ്യമാണ്. അപ്പൊ അത് വേറെ ആർക്കും മറ്റു ആ എൻവയൺമെന്റ് ആണ് ക്രിയേറ്റ് ചെയ്യേണ്ടത്. അപ്പൊ ഒരു കുടുംബത്തിലുള്ള കുടുംബാംഗങ്ങളാണ് ആ മനുഷ്യന്റെ വൈകാരികമായിട്ടുള്ള ആ ഒരു പ്രശ്നത്തെ സപ്പോർട്ട് ചെയ്യാനായിട്ട് അല്ലെങ്കിൽ ആ പ്രശ്നത്തെ അതിജീവിക്കുവാനായിട്ടുള്ള ആ ഒരു ശക്തി കൊടുക്കേണ്ടത്. പിന്നെ സൈക്കോളജിക്കൽ ആയിട്ടുള്ള ഒരു കെയർ നമുക്ക് ആവശ്യമാണ്. ഇപ്പൊ ഈ 5 ആസ്പെക്റ്റിൽ നമ്മുടെ സെൽഫ് കെയർ ഒന്ന് പരിപോഷിപ്പിക്കുകയാണെങ്കിൽ, കാരണം നമ്മൾ ഇത് ഏത് കാര്യത്തിലും ഒരു ഭാഗം താഴെ പോയാലും ഇറ്റ് വിൽ അഫക്ട് ദ ഹോൾ ബിക്കോസ് ഇറ്റ് ഇസ് ഇന്റർലിങ്ക്ഡ്. ഇതെല്ലാം ഇങ്ങനെ കണക്റ്റഡ് ആണ്. ഓരോരോ ചങ്ങലകൾ ഇങ്ങനെ കണികളായിട്ട് ഇങ്ങനെ കെട്ടപ്പെട്ടിരിക്കുന്നത് പോലെ ഇത് ഈ സെൽഫ് കെയർ എന്ന് പറയുന്നത് ഈ 5 ആസ്പെക്റ്റിലും അടിസ്ഥാനപ്പെടുത്തിയതാണ്. നമ്മുടെയൊക്കെ ആറ്റിറ്റ്യൂഡിനെ, നമ്മുടെ സാധാരണ ഈ കാനഡയിലും അമേരിക്കയിലൊക്കെ ആറ്റിറ്റ്യൂഡിനെ ഒരു നെഗറ്റീവ് ആസ്പെക്റ്റിലാണ് ഞാൻ കാണുന്നത്. ഞാൻ ഇതിനെ ഒരു പോസിറ്റീവ് ആസ്പെക്റ്റിലുള്ള ഒരു ആറ്റിറ്റ്യൂഡ് എന്നുള്ള ഒരു ടെർമിനോളജിയിലാണ് ഞാൻ ഇത് അവതരിപ്പിക്കുന്നത്. കാരണം നമ്മൾ പലപ്പോഴും നമ്മുടെ മനോഭാവം മറ്റുള്ള രോഗികളെ കാണുമ്പം, അല്ലെങ്കിൽ എന്തെങ്കിലും വേദനകളുള്ളവരെ കാണുമ്പോൾ, അല്ലെങ്കിൽ എന്തെങ്കിലും മാനസികമായിട്ടും ശാരീരികമായിട്ടുള്ള കുറവുകളുള്ള അല്ലെങ്കിൽ അങ്ങനെയുള്ള ചാലഞ്ചസ് അഭിമുഖീകരിക്കുന്ന വ്യക്തികളെ കാണുമ്പോഴുള്ള നമ്മുടെ മനോഭാവം എന്താണ്? ഡു വി റിയലി ആക്സെപ്റ്റ് ദം ആസ് അവരെ നമ്മുടെ തന്നെ ഒരു സഹോദരനായി സഹോദരിയായി നമ്മുടെ തന്നെ ഒരു കുഞ്ഞായിട്ട് കാണുവാനായിട്ടുള്ള ഒരു മനോഭാവം, അതാണ് നമുക്ക് ബേസിക് ആയിട്ടുള്ള ഒരു മനോഭാവം ഉണ്ട്. പിന്നെ പറയുന്ന ഒരു ആറ്റിറ്റ്യൂഡ് എന്ന് പറയുന്നത് എംപവറിങ് ആനിമേഷൻ. നമുക്കറിയാം എംപവർമെന്റ് എന്ന് പറഞ്ഞാൽ അവരെ ശാക്തീകരിക്കുന്ന ഒരു ആനിമേഷൻ. ആനിമ എന്ന വാക്കിന്റെ അർത്ഥം എന്ന് പറയുന്നത് ടു ഗീവ് ലൈഫ് എന്നാണ്. അപ്പൊ അതിന്റെ ആനിമ എന്ന് പറയുന്നത് ലാറ്റിൻ വാക്കാണ്. അതിന്റെ അർത്ഥം ആനിമേഷൻ അല്ലെങ്കിൽ ആനിമ എന്ന് പറയുന്നത് ടു ഗീവ് ലൈഫ്, മറ്റുള്ളവന് ജീവൻ കൊടുക്കുന്ന ഒരു ശാക്തീകരിക്കുന്ന ഒരു മനോഭാവം എനിക്കുണ്ടോ? അതൊന്ന് നമ്മളൊന്ന് അനലൈസ് ചെയ്യുന്നത് നല്ലതായിരിക്കും. മൂന്നാമത് ബീങ് എംപതറ്റിക് ഇൻ അവർ റിലേഷൻഷിപ്പ്. എംപതി പറയുന്നത് ഗെറ്റിംഗ് ഇൻ ടു ദ ഷൂസ് ഓഫ് അനദർ പേഴ്സൺ. അവന്റെ വേദനകളോടൊപ്പം ആയിരിക്കുക. കാരണം നമ്മളിങ്ങനെ മാറി നിന്ന് ചിന്തിക്കുന്നു, നമ്മുടെ കാര്യവും നമ്മുടെ കുടുംബവും നമ്മൾ സ്വസ്ഥമായിട്ട് പോകുന്നു, നമ്മുടെ മക്കൾ നന്നായി പഠിക്കുന്നു, അവർക്ക് നല്ല തൊഴിലുണ്ട്, അല്ലെങ്കിൽ ഞാൻ നന്നായിട്ട് തൊഴിൽ ചെയ്യുന്നു, എൻ്റെ സാമ്പത്തിക ഭദ്രത എനിക്കുണ്ട്, എൻ്റെ കുടുംബം ഭദ്രമാണ് എന്നൊക്കെ നമ്മൾ പറയുമ്പോഴും നമ്മുടെ തൊട്ടടുത്ത് അല്ലെങ്കിൽ നമ്മുടെ ചുറ്റുപാടുകൾ, നമുക്കറിയാവുന്ന കുടുംബങ്ങൾ, നാട്ടിലുള്ള കുടുംബങ്ങൾ ഒക്കെ വേദനയിലൂടെ കടന്നു പോകുന്നവരുണ്ട്. അപ്പൊ അവരെയൊക്കെ ഒന്ന് സഹായിക്കാൻ ചിലപ്പോൾ ഒരു ഫോൺ കോൾ ആയിരിക്കും. ഞാൻ ഇന്ന് എന്നോട് പഠിച്ച എൻ്റെ ഒരു സുഹൃത്തിനെ വിളിച്ചപ്പോഴത്തേക്ക് പറഞ്ഞത് ഇപ്രകാരമാണ്: അച്ഛൻ വേറെ ഒന്നും ചെയ്തില്ലെങ്കിലും ഈശോയോടൊന്ന് പ്രാർത്ഥിച്ചാൽ മാത്രം മതി. ഈശോയോടൊന്ന് പ്രാർത്ഥിച്ചാൽ മാത്രം. കാരണം അപ്പന്റെ സ്ഥിതി എന്ന് പറയുന്ന ലങ്സ് പ്രോബ്ലം ഉള്ള വ്യക്തിയാണ്. അപ്പം അദ്ദേഹത്തിന്റെ അവസ്ഥ വളരെ മോശമാണ്. അപ്പം വെറും 10% മാത്രമാണ് ഡോക്ടേഴ്സ് ആ വ്യക്തി ജീവിക്കുമെന്ന് പറഞ്ഞിരിക്കുന്നത്. ഇന്നലെയാണ് ഡോക്ടർ അങ്ങനെ പറഞ്ഞത്. അപ്പം സ്വാഭാവികമായിട്ട് ആ ഒരു സുഹൃത്തിന് വേണ്ടത് ചിലപ്പോൾ അന്നേരം ഒരു ഇമ്മീഡിയറ്റ് ആയിട്ടുള്ള ഒരു ഫോൺ കോൾ ആയിരിക്കും. നമ്മളത് പിന്നീട് എന്ന് പറഞ്ഞ് നമ്മൾ മാറ്റിവെച്ചാൽ ചിലപ്പം ആ ഒരു ശക്തി, ആ ഒരു പ്രതീക്ഷ കൊടുക്കുവാനായിട്ട് സാധിക്കുകയില്ല. അതുകൊണ്ട് പ്രതീക്ഷയാണ് നമ്മുടെ ജീവിതം, പ്രാർത്ഥനയാണ് നമ്മുടെ സമാധാനം, പിന്നെ സ്നേഹമാണ് നമ്മുടെ ബന്ധങ്ങൾ. ഇപ്പൊ ആ ജോയ് ഫിൽഡ് ലൈഫ് പോസിബിൾ, ഒരു ആനന്ദകരമായിട്ടുള്ള ഒരു ഹൃദയത്തിന് സന്തോഷമുള്ള ഒരു ജീവിതം എനിക്ക് ജീവിക്കുവാനായിട്ട് സാധിക്കുന്നുണ്ടോ? കാരണം ഇതിനകത്ത് ഇൻക്രെഡിബിൾ ജോയ് വേഴ്സസ് ടെറിബിൾ സാഡ്നെസ് എന്ന് പറയുന്ന ഒരു കോൺസെപ്റ്റ് ഉണ്ട്. കാരണം എപ്പോഴും നമ്മൾ കംപ്ലൈനിങ് ആറ്റിറ്റ്യൂഡാണ്, നമ്മൾ കംപ്ലൈൻസ് മാത്രമാണ് കാണുന്നുണ്ടെങ്കിൽ നമുക്ക് നഷ്ടപ്പെടാൻ സാധ്യതയുള്ള ഒരു സന്തോഷം, അതെന്ന് പറയുന്നത് ഇൻക്രെഡിബിൾ ആയിട്ടുള്ള ജോയ്, അത് പറഞ്ഞറിയിക്കാൻ പറ്റാത്ത ആ ഒരു സന്തോഷം, അതായത് ഇന്നർ ഹാപ്പിനെസ് വേഴ്സസ് മൊമെന്ററി പ്ലഷേഴ്സ് എന്ന് പറയാറുണ്ട്. കാരണം നമ്മുടെ മൊമെന്ററി പ്ലഷേഴ്സിൽ മാത്രം നമ്മൾ ഇടപെടുകയാണെങ്കിൽ നമുക്ക് നഷ്ടപ്പെടാനായിട്ട് സാധ്യതയുള്ള ഒരു വലിയ ഒരു ആസ്പെക്ട് എന്ന് പറയുന്നത് ഇന്നർ ഹാപ്പിനെസ് ആണ്. നമ്മുടെ ഉള്ളിലുള്ള ആ ഒരു സമാധാനം, ആ ഒരു സന്തോഷം. പിന്നെ എവർലാസ്റ്റിംഗ് പീസ് വേഴ്സസ് ഫ്രസ്ട്രേറ്റഡ് ലൈഫ്. നമ്മൾ എപ്പോഴും ഒരു ഫ്രസ്ട്രേറ്റഡ് ലൈഫ് ജീവിക്കുന്ന വ്യക്തിയാണെങ്കിൽ നമ്മുടെ ചുറ്റുപാടും ആ ഒരു എൻവയൺമെന്റ് ആയിരിക്കും നമ്മൾ ക്രിയേറ്റ് ചെയ്യുന്നത്. അപ്പം ഒന്ന് ഓർക്കാം, നമ്മുടെ ആ റിയൽ സോഴ്സ് ഓഫ് ജോയ് ഇസ് ജീസസ് ക്രൈസ്റ്റ്. നമ്മൾ ചിലപ്പോൾ സന്തോഷം കണ്ടെത്തുന്നത് നമ്മുടെ മക്കളിലാകാം, നമ്മുടെ ബാങ്ക് സേവിങ്ങിലാകാം, നമ്മുടെ മറ്റ് പൊസഷൻസിലാകാം, നമുക്കുള്ള മറ്റു നേട്ടങ്ങളിലാകാം, പദവികളിലാകാം. അതിലൊന്നും ആകരുത്. അവർ റിയൽ സോഴ്സ് ഓഫ് ജോയ് ഈസ് ജീസസ് ക്രൈസ്റ്റ്. ഈശോയിൽ മാത്രമാണ്. കീപ് യുവർ ഫേസ് ഓൾവേസ് ടുവേർഡ് ക്രൈസ്റ്റ് ആൻഡ് ദ പ്രോബ്ലംസ് വിൽ ഫോൾ ബിഹൈൻഡ് യു എന്ന് പറയാറുണ്ട്. കർത്താവിലേക്കാണ്. അപ്പൊ ഐ ആം ദ ലൈറ്റ്, പ്രകാശപൂർണനായ കർത്താവിലേക്ക് നിന്റെ പ്രശ്നങ്ങളെ അവതരിപ്പിക്കുകയാണ്. അപ്പം നിന്റെ മുമ്പിൽ വീശിയടിക്കുന്ന കാറ്റുണ്ട്, നിന്റെ മുന്നിൽ ആഞ്ഞടിക്കുന്ന തിരയുണ്ട്. പക്ഷെ ആ തോണിയിൽ നിശബ്ദനായി ഉറങ്ങുന്ന ഒരു ദൈവമുണ്ടെന്നുള്ള ആ ഒരു ചിന്ത. അപ്പം ഈ ആഞ്ഞടിക്കുന്ന തിരയ്ക്കും മുന്നിൽ വീശിയടിക്കുന്ന കാറ്റിനും ഒക്കെ അതിജീവിക്കുവാനായിട്ടുള്ള ശക്തി ഈ തമ്പുരാൻ നമുക്ക് തരുന്നുണ്ട്. ഐ ആം ദ ലൈറ്റ് ഓഫ് ദ വേൾഡ് എന്ന് യോഹന്നാന്റെ സുവിശേഷം 8-ാമത്തെ അധ്യായം 12-ാമത്തെ വാക്യത്തിലുള്ള കർത്താവ് നമ്മളെ പഠിപ്പിക്കുന്നതാണ്. ഇപ്പോ ഈ ഇപ്പോഴത്തെ ഈ കാലഘട്ടത്തിന്റെ തന്നെ വലിയ ഒരു പ്രവാചകനാണ് ഫ്രാൻസിസ് മാർപ്പാപ്പ. അദ്ദേഹം എഴുതിയ ഒരു ജോയ് ഓഫ് ദ ഗോസ്പൽ എന്ന് പറയുന്ന ഒരു അപ്പസ്തോലിക് എക്സർട്ടേഷൻ ഉണ്ട്. അതിൽ മിഷണറി ജോയെ പറ്റി പറയുന്നുണ്ട്. അതായത് ഈ സ്ലീഹന്മാർ 72 പേരെ അയച്ചു കഴിയുമ്പോൾ അവര് പോയി വിവിധ പട്ടണങ്ങളിലും വില്ലേജുകളിലും ഒക്കെ ഈശോയെ പറ്റി പ്രസംഗിച്ചു, സുവിശേഷം പ്രസംഗിച്ച് അത്ഭുതങ്ങളൊക്കെ നടത്തി തിരികെ വന്നിട്ട് അവർ ഷെയർ ചെയ്യുന്ന ആ ഒരു ആസ്പെക്ട് ഉണ്ട്. എനിക്ക് തോന്നുന്നു നമ്മുടെ ജീവിതത്തിലെ എല്ലാ നിമിഷങ്ങളും ഈ ഒരു മിഷണറി ജോയ് ഉണ്ടാകണം. ആ ഒരു മിഷണറി സന്തോഷമില്ലെങ്കിൽ നമ്മളെല്ലാം വളരെ ദുഃഖത്തിലേക്ക് പോകും. എപ്പോഴും ആൻസൈറ്റിയും ഫ്രസ്ട്രേഷനും മാത്രമേ നമുക്ക് ഷെയർ ചെയ്യാനായിട്ട് ഉണ്ടാവുകയുള്ളൂ. ഇപ്പൊ ഇൻക്ലൂഷൻ ഓഫ് പുവർ ഇൻ ദ സൊസൈറ്റി, ഇതൊരു വലിയ ഒരു ഈ മാർപ്പാപ്പ അല്ലെങ്കിൽ ഇദ്ദേഹം പങ്കുവച്ച ഏറ്റവും വലിയൊരു സന്ദേശം. നമ്മളത് എങ്ങനെയാണ് ഒരു പാവപ്പെട്ടവനെ കൂടെ എൻ്റെ ജീവിതത്തിന്റെ മേഖലകളിലേക്ക് കൊണ്ടുവരാനായിട്ട് സാധിക്കുന്നത്, എങ്ങനെ അവനെ ഒന്ന് ഉദ്ധരിക്കുവാനായിട്ട് എനിക്ക് സാധിക്കും. ആ ഒരു വലിയ ഒരു ആസ്പെക്ട് അവിടെ അവതരിപ്പിക്കുന്നത്. പിന്നെ പറഞ്ഞ ഒരു ചിന്ത സോഷ്യൽ ഡയലോഗാണ്. ഈ സോഷ്യൽ ഡയലോഗിന്റെ ഏറ്റവും ബെസ്റ്റ് എക്സാമ്പിൾ ആണ് നമ്മൾ ഇന്ന് എക്യുമെനിക്കൽ കൗൺസിലൂടെ, പ്രത്യേകിച്ച് ടൊറന്റോയിൽ എനിക്ക് ഉള്ള ഗ്രേറ്റർ അപ്രിസിയേഷൻ അതിനാണ്. അപ്പോൾ ആ ഒരു എക്യുമെനിക്കൽ കൗൺസിലൊക്കെ എല്ലാ ഡിനോമിനേഷൻസും ഒരുമിച്ച് വന്ന് പ്രാർത്ഥിക്കുവാനും വചനം പങ്കുവെക്കുവാനും കുറച്ച് സമയം ചെലവഴിക്കുവാനും അല്ലെങ്കിൽ വചനത്തിലൂടെയൊക്കെ കടന്നു പോകുവാനും ഗാനങ്ങൾ ആലപിക്കുവാനും ഒക്കെ അതെല്ലാം സാധിക്കുന്നത് ഈ സോഷ്യൽ ഡയലോഗ് എന്നുള്ളൊരു പ്ലാറ്റ്ഫോം അവിടെ ഉള്ളത് കൊണ്ട് മാത്രമാണ്. അങ്ങനെയാണ് നമ്മൾ സ്പിരിറ്റ് ഫിൽഡ് ഇവാഞ്ചലൈസേഴ്സ് ആയി മാറുന്നത്. അപ്പൊ എനിക്ക് ഞാനൊന്ന് ക്രോഡീകരിക്കുകയാണ് നമ്മൾ ഇതുവരെ പങ്കുവെച്ച കുറച്ച് ചിന്തകൾ. എങ്ങനെയാണ് ഒരു മനുഷ്യനെ മറ്റൊരു വ്യക്തിയുടെ ജീവിതത്തെ സ്പർശിക്കുവാനായിട്ട് സാധിക്കുന്നത്? ഇപ്പം ദൈവം ചുംബിച്ച മുഖപ്പാടുകൾ എന്ന് പറഞ്ഞ് ആ ഒരു ക്യാൻസർ ബാധിച്ച ഒരു മനുഷ്യൻ, ഒരു സുഹൃത്തിന് അത് ദൈവം സ്പർശിച്ച മുഖപ്പാടാണെന്ന് അവന് പറയുവാനായിട്ട് സാധിക്കുന്നുണ്ടെങ്കിൽ, പ്രിയപ്പെട്ടവർ, അത് തന്നെയാണ് ഏറ്റവും വലിയ വളരെ വളരെ വ്യത്യസ്തമായിട്ടുള്ള ഒരു ദൈവാനുഭവം എന്ന് പറയുന്നത്. നമ്മുടെ ജീവിതത്തിലെ അതിനെ ഒരു കുറവാണ് എന്ന് പറയുന്നതിലുപരി അത് ദൈവം ചുംബിച്ചതാണ്, ദൈവം സ്പർശിച്ചതാണെന്ന് പറയുമ്പോൾ അതിനൊരു വലിയ ഒരു അർത്ഥം ഉണ്ടാവുകയാണ്. അതുകൊണ്ടാണ് ഒരു കവിതയിൽ ONV പ്രകാരം പറഞ്ഞത്, ചിതയിൽ നിന്നു ഞാൻ ഉണർന്നെഴുന്നേൽക്കും, ചിറകുകൾ പൂവുപോൽ വിടർന്നെഴുന്നേൽക്കുമെന്ന്. ഇപ്പൊ ചിത എന്ന് പറയുന്നത് മരണം പിന്നീട് നമുക്കൊരു വേറൊരു കാര്യം അവിടെ ഇല്ല. ആ ചിതയിൽ നിന്ന് ഞാൻ ഉണർന്നെഴുന്നേൽക്കും. ചിറകുകൾ എന്ന് പറഞ്ഞ വലിയ പ്രത്യാശയുടെ പ്രതീകമാണ്. ചിറകുകൾ പൂവ് പോൽ എന്ന് പറഞ്ഞ പൂക്കൾ വീണ്ടും വലിയൊരു പ്രത്യാശയുടെ പ്രതീകമാണ്. പൂക്കൾ പോലെ വിടർന്നെഴുന്നേൽക്കും. ഇപ്പൊ നമ്മുടെയൊക്കെ ജീവിതത്തിന്റെ മരണമുഖത്ത് നിന്ന് ചിറകുകൾ അടിച്ച് പൂക്കളെ പോലെ പറന്നുയരുവാനായിട്ടുള്ള ആ വലിയൊരു ദൗത്യം ദൈവം നമ്മളെ ഏൽപ്പിച്ചിട്ടുണ്ട്. അതാണ് നമുക്ക് പങ്കുവെക്കുവാനായിട്ടുള്ള പ്രത്യാശയുടെ സുവിശേഷം എന്ന് പറയുന്നത്. ഇപ്പൊ ടേക്കിംഗ് കറേജിയസ് സ്റ്റെപ്സ്. കാരണം ചില സമയത്ത് നമുക്ക് വോളണ്ടിയേഴ്സ് ഇല്ല. പല കാര്യങ്ങളിലും നമ്മൾ പലരെയും വിളിക്കും, ബന്ധപ്പെടും. പക്ഷെ അന്ന് ഇനിഷ്യേറ്റീവ് എടുക്കുവാനായിട്ടുള്ള പലപ്പോഴും നമ്മുടെ തിരക്കുകൾ കാരണം അല്ലെങ്കിൽ നമ്മൾ പല പല എക്സ്ക്യൂസസ് ഒക്കെ നമ്മൾ അതിൽ കണ്ടെത്താറുണ്ട്. ചില കാര്യങ്ങൾ ചില സോഷ്യൽ മൂവ്മെന്റ്സിലൊക്കെ നമുക്ക് പങ്കെടുക്കുവാനായിട്ട് ഒരു ദിവസം അറ്റ്ലീസ്റ്റ് ഒരു മണിക്കൂർ അല്ല 2 മണിക്കൂറെങ്കിലും വോളണ്ടിയർ ചെയ്യാനായിട്ട് നമുക്ക് സമയം കിട്ടുകയാണെങ്കിൽ, അതിനുള്ള മനസ്സുണ്ടെങ്കിൽ, ഏറ്റവും വലിയ ഒരു സോഷ്യൽ ആസ്പെക്റ്റിലൂടെയൊക്കെ കാണുമ്പോൾ സോഷ്യൽ ആസ്പെക്റ്റിനേക്കാളും നമ്മുടെ ആത്മീയമായിട്ടുള്ള ജീവിതത്തിൽ ദൈവം വില കൽപ്പിക്കുന്ന ചില നിമിഷങ്ങളായി മാറും. കാരണം ഞാൻ ആ അനാഥാലയം കൊല്ലത്ത് ആരംഭിച്ചപ്പോൾ എനിക്ക് ഉണ്ടായ ഏറ്റവും പ്രധാനപ്പെട്ട ഒരു ബുദ്ധിമുട്ടെന്ന് പറയുന്നത് വോളണ്ടിയേഴ്സിനെ ആവശ്യപ്പെടുമ്പോൾ നമുക്ക് അവിടെ ലഭിക്കുന്നുണ്ടായിരുന്നില്ല. പക്ഷെ നമ്മൾ ഒരു സാലറി കൊടുത്തു സ്റ്റാഫിനെ അപ്പോയിന്റ് ചെയ്യാനായിട്ടാണെങ്കിൽ അന്ന് 300ഓളം പേര് ബയോഡേറ്റയുമായി വന്നു. അപ്പൊ എനിക്ക് തോന്നി ഏറ്റവും കൂടുതൽ ഇന്ന് മനുഷ്യൻ ആവശ്യമുള്ളത് പണമാണ്. പണം വേണ്ട എന്നല്ല, പക്ഷെ നമ്മുടെ ഒരു മനോഭാവത്തിൽ നമ്മൾ പണത്തെ സ്നേഹിക്കുകയും മനുഷ്യനെ ഉപയോഗിക്കുകയും ചെയ്യുന്ന ഒരു നിലപാടെടുക്കുന്നുണ്ട്. നേരെ തിരിച്ച് മനുഷ്യരെ സ്നേഹിക്കുകയും പണത്തെ ഉപയോഗിക്കുകയും ചെയ്യുന്ന ആ ഒരു റീഡിഫൈനിങ് അവർ മെന്റാലിറ്റി, അല്ലെങ്കിൽ ആ ഒരു മനോഭാവത്തിലുള്ള ഒരു മാറ്റം വരേണ്ടതുണ്ട്. വീണ്ടും പുറപ്പാടിന്റെ പുസ്തകം 33-ാമത്തെ അധ്യായം 12-ാമത്തെ വാക്യത്തിൽ വചനം പറയുന്നത്, എനിക്ക് നിന്നെ നന്നായിട്ടറിയാം, നീ എൻ്റെ പ്രീതി നേടിയിരിക്കുന്നു. ഏറ്റവും സുന്ദരമായ ഒരു പ്രത്യാശയുടെ വചനമാണ്. നമുക്ക് ഭയമല്ല, പ്രത്യാശയാണ് ആവശ്യം. അതുകൊണ്ടാണ് യെശയ്യാ പ്രവാചകന്റെ പുസ്തകം 40-ാമത്തെ അധ്യായം 31-ാമത്തെ വചനം വീണ്ടും പറയുന്നത്, ദൈവത്തിൽ ആശ്രയിക്കുന്നവൻ വീണ്ടും ശക്തി പ്രാപിക്കും, അവൻ കഴുകന്മാരെ പോലെ ചിറകടിച്ചുയരും, അവർ ഓടിയാലും ക്ഷീണിക്കുകയില്ല, നടന്നാൽ തളരുകയുമില്ല എന്നാണ്. അപ്പോ വീണ്ടും അവിടെ കഴുകനെ പോലെ ചിറകടിച്ചുയരുമെന്നാണ്. അപ്പൊ അതും വീണ്ടും ഒരു പ്രത്യാശയുടെ വചനമാണ് യെശയ്യാ പ്രവാചകൻ നമ്മുടെ മുമ്പിലേക്ക് അവതരിപ്പിക്കുന്നത്. കർത്താവ് പറഞ്ഞ ഏറ്റവും സുന്ദരമായ ഒരു പ്രത്യാശയുടെ വചനം എന്ന് പറയുന്നത്, ഞാൻ നിങ്ങളെ അനാഥരായി വിടുകയില്ല. ആ അനാഥർ എന്ന് പറയുന്ന വാക്കിന്റെ റൂട്ട് വാക്കിലേക്ക് ഞാനൊന്ന് പോയി. അതിന്റെ എറ്റിമോളജി നമ്മൾ പഠിപ്പിക്കുന്നത് ഇപ്രകാരമാണ്. നമ്മൾ ഉപയോഗിക്കുന്ന ഇംഗ്ലീഷിൽ ഉപയോഗിക്കുന്ന വാക്ക് ഓർഫണേജ് അല്ലെ ഓർഫൻസ് എന്ന, അനാഥർ എന്ന് പറയുമ്പോൾ ഓർഫൻസ് എന്ന വാക്കാണ്. അപ്പൊ അതിന്റെ ഗ്രീക്ക് പദം എന്ന് പറയുന്നത് ഓർഫണോസ് എന്നാണ്. ഓർഫണോസ് എന്ന് പറയുന്നതിന്റെ അർത്ഥം, ഈ ഒരു കോൺസെപ്റ്റ് ഉണ്ടായതിന്റെ ചരിത്രം തന്നെ, പണ്ട് ഗ്രീക്ക് ഫിലോസഫർ ആയിരുന്ന സോക്രട്ടീസ് മരിച്ചു കഴിഞ്ഞപ്പോൾ പ്ലേറ്റോ ശിഷ്യനും ബാക്കിയുള്ള ശിഷ്യന്മാരെല്ലാം ഒരു അപ്പൻ ഉറങ്ങിയ വീടിന് തുല്യമായി. കാരണം ഒരു അപ്പനെ പോലെ കൊണ്ടു നടന്ന ഒരു ഫിഗറാണ് സോക്രട്ടീസ്. ആ സോക്രട്ടീസ് മരിച്ചു എന്ന് കഴിഞ്ഞപ്പോൾ അവർക്ക് അത് അക്സെപ്റ്റ് ചെയ്യാനായിട്ട് സാധിക്കുന്നില്ല. അപ്പൊ അപ്പനെ നഷ്ടപ്പെട്ട ആ ഒരു അവസ്ഥയിൽ അവര് കോർഡിനേറ്റ് ചെയ്ത ഒരു വാക്കാണ്. അപ്പൊ ഓർഫണേജ് എന്ന് പറയുന്നത് അപ്പനില്ലാത്ത വീടെന്നാണ്. അപ്പൊ അനാഥർ എന്ന് പറയുന്ന വാക്കെന്ന് പറയുന്നത്, കർത്താവ് പറയാണ്, ഞാൻ നിങ്ങളെ അനാഥരായി വിടുകയില്ല. അപ്പൊ ഈവൻ അനാഥരായി ജനിച്ച കുട്ടികളെ പോലും ദൈവം അനാഥരാക്കുന്നില്ല എന്നാണ്. ദൈവത്തിന്റെ മുമ്പിൽ അവർ സ്വീകാര്യരാണ്. ആ ഒരു സന്ദേശമാണ് പ്രിയപ്പെട്ടവരെ. സാധാരണ ഞാൻ ജീവിതത്തെ പറ്റി നമ്മൾ പറയുന്നത് ഇന്നലകളെ പറ്റി പറയും, ഇന്നുകളെ പറ്റി പറയും, നാളുകളെ പറ്റി പറയും. ജീവിതത്തിന്റെ രത്നച്ചുരുക്കം എന്ന് പറയുന്നാൽ ഇന്നലകളിൽ ഉണ്ടായ ചില അനുഭവങ്ങൾ, ഇന്ന് നമ്മൾ നടത്തുന്ന ചില പരീക്ഷണങ്ങൾ, നാളെ നമ്മുടെ പ്രതീക്ഷകൾ, ഇത് മൂന്നും കൂടെ കോർത്തിണക്കുമ്പോഴാണ് നമ്മുടെ ജീവിതമാകുന്നത്. അല്ലെങ്കിൽ നമ്മുടെ ജീവിതത്തിൽ നമ്മൾ എടുക്കുന്ന ചെറുതും വലുതുമായിട്ടുള്ള അനേകായിരം തീരുമാനങ്ങളുടെ ആകത്തുകയാണ് നമ്മുടെ ജീവിതം. അപ്പൊ അങ്ങനെയുണ്ടെങ്കിൽ നമുക്ക് ഈ പ്രത്യാശയുടെ വചനം പങ്കുവെക്കുന്നവരാകാം. ഹെൽപ്പിംഗ് പേഷ്യൻസ്, കാരണം പലപ്പോഴും പല രോഗികളെയും സഹായിക്കാൻ ആരുമില്ല. കോവിഡ് ബാധിച്ചെന്ന് പറഞ്ഞാൽ പിന്നെ ആ ഭാഗത്തേക്ക് പോവില്ല. അസിസ്റ്റിംഗ് വീക്ക് പീപ്പിൾ, ഫോർഗിവിങ് വൺ അനദർ, നമ്മൾ ക്ഷമിക്കാതെ നമ്മൾ പ്രാർത്ഥിച്ചിട്ട് കാര്യമില്ല എന്ന് വചനം വ്യക്തമായിട്ട് നമ്മളെ പഠിപ്പിക്കുന്നുണ്ട്. അപ്പൊ ക്ഷമിച്ച് പ്രാർത്ഥിക്കുന്ന വ്യക്തികളാകാം. ബീയിങ് വിജിലന്റ്, വളരെ ഉണർവോടെ ഇരിക്കുന്ന വ്യക്തികളാകാം. അപ്പോ അങ്ങനെ പ്രതീക്ഷയുടെ പ്രത്യാശയുടെ ആ ഒരു സന്ദേശം പങ്കുവയ്ക്കുവാനായിട്ട് നമുക്ക് പരിശ്രമിക്കാം. എനിക്ക് നൽകിയ ഈ ഒരു അവസരത്തിന് പ്രത്യേകമായിട്ട് നന്ദി പറയുന്നു. ബഹുമാനപ്പെട്ട ജിബിനച്ഛനെ ഞാൻ നന്ദിയോടെ ഓർക്കുന്നു. പ്രകാശേട്ടനെയും ജാക്കിനെയും ഒക്കെ പരിചയപ്പെട്ടവരെ എല്ലാവരെയും, ഇന്ന് എന്നെ ശ്രവിച്ച ഒരുപാട് പേരുണ്ട്. ടൊറോണ്ടോയിൽ നിന്ന് എനിക്ക് പെട്ടെന്ന് കാണാൻ പറ്റുന്ന ചേച്ചി പങ്കെടുക്കുന്നുണ്ട്. ഇന്ത്യയിൽ നിന്ന് എൻ്റെ നാട്ടിൽ നിന്ന് എൻ്റെ അമ്മയും സഹോദരനും ഈ ടോക്കിൽ സഹോദരങ്ങളും പങ്കെടുക്കുന്നുണ്ട്. അതോടൊപ്പം തന്നെ വിവിധ പ്രദേശങ്ങളിലും പ്രത്യേകിച്ച് ടൊറോണ്ടോയിലായിരുന്നുകൊണ്ട് ഈ ടോക്കിൽ പങ്കെടുത്ത എന്നെ ശ്രവിച്ച എല്ലാവർക്കും നന്ദി പറയുന്നു. നമുക്ക് ഈ പ്രത്യാശയുടെ ആ വലിയ സുവിശേഷം പങ്കുവെക്കുന്ന വ്യക്തികളാകാം. ദൈവം നിങ്ങളെല്ലാവരെയും സമൃദ്ധമായിട്ട് അനുഗ്രഹിക്കട്ടെ. ആമേൻ. Thank you.
Thank you, Achan, for the wonderful speech and for reminding us again that the most important way is the doctor-patient relationship. More important is the humanistic touch, the human relationship, for treating others as a fellow human being, right? ഒരു ഡോക്ടറിനും ചെയ്യാൻ പറ്റാത്തതിനെക്കാട്ടിലും ഏറ്റവും കൂടുതലുള്ള അത്ഭുതമുള്ള the God is within each of us, and we have to recognize God is within each one of us. And in order to do that, we have to view each other not from a position, but from as a fellow human being, with respect and with dignity and honor. And so thank you so much, Achan. A big thank you for waiting so patiently. I know Achan actually almost Aramanikura delayed Achan the original start time. Achan, I think he had other commitments he might have missed out. So we're sorry for that. And we thank you, a big thank you from all of us in Toronto. And stay safe in America. Avada COVID especially Indiana. So once again, thank you so much, Achan.
Thank you. Bye.
And so I think we covered sort of a humanistic touch. We covered a sort of a physical aspect or a medical science background. And I think the last speaker for today will touch on the mental health aspect. And there's so many theories behind depression, right? And in order to tackle depression, we need to understand why it happens, because without understanding the enemy, how can you expect to defeat it? And there's some theories that they claim that depression is really an evolutionary tool that's designed to be beneficial to you. There's a theory that it's called the psychic pain hypothesis, that depression is actually an emotion to inform you that you are actually doing something bad or something damaging to yourself, and you need to change something in your life, adapt. There's another theory called behavior shutdown model, where they claim that if something has a low risk to reward ratio, then you start feeling depressed, because it's a internal warning mechanism. There's another theory called analytical rumination hypothesis, where depression is thought of as a way to focus and hyper-focus and analyze on solving a particular problem in your life by ruminating. But unfortunately, what happens is that this rumination leads to being more harmful for so many people than beneficial. There's another theory called rank theory, where it says that depression actually helps you avoid a fight instead of running into a fight in order to prevent harm from happening to you. There's another theory called social risk hypothesis, where they say that depression is actually an emotion to help you understand that being isolated and lonely, depression is a tool to sort of make you realize that you should not lose your social bonds. And there's another theory called third ventricle hypothesis, where they say, where the theory is that they think that a lot of the physical manifestations of depression, with the averted gaze and with the poor posture, the hunched over posture, is actually an inbuilt mechanism by the brain with a lot of the nuclei in the third ventricle, in order to help you avoid being attacked when you're in a hostile environment. When the brain thinks you're in a hostile environment, depression is a way to help you keep a low profile so you don't get singled out or attacked. But the real breakthrough in depression theories, or understanding depression, came in 1976 by a psychiatrist by the name of Dr. Aaron Beck in America, in Pennsylvania. He's actually considered the father of cognitive therapy and cognitive behavioral therapy. Dr. Beck proposed something called cognitive theory of depression. And part of that is something called Beck's cognitive triad, where there's 3 key elements in a person's belief system that involves automatic, spontaneous, and seemingly uncontrollable negative thoughts. And those 3 key elements are: 1, the self, your thoughts about yourself; number 2, the world, your thoughts about the world; and number 3, the future, what you think about the future. And when you have negative thoughts in all three of these dimensions. You develop, basically, that's the theory of what they believe that leads to the foundation or etiology of depression. What eventually happens is that we have something called the cognitive distortions, but I think the next speaker will elaborate more into detail into that sort of cognitive biases or errors in our thinking or unhealthy wrong patterns of thinking. All or nothing thinking, overgeneralization, mental filters, jumping to conclusions, catastrophizing, disqualifying the positive, labeling, personalization, perfectionism, emotional reasoning. And they all act as a feedback loop, which worsens the depression. And this loop keeps going back and back in a feedback mechanism. And CBT is one of the ways that they find in helping a person with depression by finding a way to stop that negative feedback loop. And stop that negative self-talk and put an end to it. And that actually helps people recover from depression quite effectively. And most often they don't need medication. And again, I think the next speaker will go more into CBT. So without further ado, I would like to invite the next speaker for today. She's currently working as a mental health social worker with the Halton Healthcare in Oakville. She's a registered social worker, having obtained her MSW from Indoor School of Social Work. And she also has an MPhil in psychiatric work from NIMHANS, which is the National Institute of Mental Health and Neurosciences in Bangalore, which is the apex institute for mental health and neurosciences in India, as most of you know. Before immigrating to Canada in 2005, she was working in Bangalore with England-based Richmond Fellowship Society Postgraduate College for Psychosocial Rehabilitation. In Canada, as a clinical social worker with Trillium Health Partners in Mississauga in 2006. She currently works with outpatient mental health services in Oakville Trafalgar Memorial Hospital, where she teaches cognitive behavioral therapy, mindfulness, and behavioral activation to clients. And she's part of a multidisciplinary team where she holds the title of case manager. So having 24 years of experience in working with adults with persistent mental health conditions, and advocating for mental health awareness as well, we can all gain some valuable insight by listening to our next speaker, especially with this topic today, which is so pertinent to their area of expertise. So it's my pleasure to invite our next speaker, Sheba Matthew, and many of you would already know Sheba Auntie from our church as well. So the floor is yours.
Thank you, Jack, for giving that great introduction. Hi, everyone, respected Jibin Achan, Father Pius, and all the Achans here with us today. I would like to thank the organizers of this retreat as well as Jack for introducing me to the audience. We had a great discussion with the first two speakers, Dr. Joseph, who gave us a very informative presentation. Also, Father Pius, from a spiritual perspective, it was very insightful to learn his experiences with faith. I feel privileged and honored to be given this platform to share my knowledge on today's topic, which is struggling with despair, hopelessness, stress, and anxiety. And on that note, let's get started. So today, we'll be going over 4 main sections. Here's a brief outline on what I'll be covering today, starting with what is stress and anxiety. Then we'll talk a little bit about managing anxiety, moving on to the next topic, which is hopelessness and despair. And lastly, we'll finish off with some techniques and methods for coping with hopelessness and despair. So let's start off with the first section, what is stress and anxiety? So Kelly McGonigal, an expert in the field of stress research, describes stress as the discomfort that arises when something we care about is at stake. Stress also has physical symptoms or physical reactions that manifest in physical forms. And those include like racing heart, sweaty palms, funny feeling in the tummy, or it's like overall uneasy feeling, also known as stress response. There are 2 main branches of stress responses. The first one is the fight or flight response. The fight or flight response is very primitive stress response that dates back to thousands of years. Fight also refers to facing the stressor and dealing with perceived danger. And fight refers to avoiding, and flight response refers to avoiding the stressor and preventing any contact with it. The other major stress response is the tend and befriend response, which encourages us to reach out for social support. It helps us to strengthen our social ties. It is also used for mutual defense against the stressor. On to the next one, I want to talk about a more specific aspect of stress. Now I know many of us on here in this present situation, we undergo stress on a daily basis. I'll help you put a term to the actual experience. What I'm talking about is auto stress. So auto stress is the result of our body's stress response running for a prolonged period of time. It damages the immune system, attacks the body instead of protecting it, and transforms the stress response into a very destructive system. So the key thing here is that there is a prolonged response to stress. If you're feeling stressed on an ongoing basis and on a regular basis, it is not healthy. It is doing more damage than good. Let's look at some signs and symptoms of auto stress. Those include chest tightness or feeling uneasy in the chest, tension in your muscles, headaches, difficulty sleeping, feeling restless, sort of mental restlessness, and also not able to relax. And people might also experience heart palpitations or irregular heart rhythm. There are also digestive issues that occur with auto stress. This may be a result of your body being in a state of prolonged stress. Moving on to the next slide, anxiety is best described as unhelpful thinking patterns we experience when our mind fixates on threat, uncertainty, and negativity. The two major aspects of anxiety are the physical and the mental components. The physical symptoms would be similar to the auto stress that we just talked about. It's mostly the bodily reactions. The mental components include feeling tensed, nervous, inability to concentrate, having overwhelming thoughts, or feeling some sort of uneasy, feeling inevitable panic or danger. Anxiety can occur on its own as a response to stress, or it can trigger a stress. It is very important to understand that you actually cannot control anxiety from occurring. It is your brain's automatic survival mechanism. The only things we can control is our emotional responses to the anxiety and how we respond to anxiety. So when we are talking about anxiety, there are a couple of major things you should look out for. First one is threat scanning. Another one is catastrophizing. Then there is hypothetical worry. There's also emotional reasoning. And the last one I'll be talking about is fortune telling. These are some of the common ones. I know Jack mentioned much more, but these are the most common ones that people go through. And so I'll just try to explain with some examples as well. Let's try to understand what each of these terms mean. So threat scanning. Threat scanning is when your mind searches the environment for what you fear. This can be conscious or subconscious. It's also associated with your mind assigning meaning to harmless events. A good example for this in the current situation that we are battling with is the COVID situation, where people frequently check your body for COVID symptoms. Another example would be excessively checking the news for coronavirus updates. So there is a fixation about you getting the symptoms or you contracting the virus. Moving on to the next one, it's called catastrophizing. It is all about when your mind jumps to worst case scenarios. You're thinking of catastrophes. There's a well-known saying which captures the essence of catastrophizing, and that is making a mountain out of a molehill. This is essentially talking about making a very big deal out of something that is very trivial in reality. Someone that catastrophizes always thinks the worst will happen to them. An example for this is assuming that you have COVID-19 based on the fact that you have chest tightness or you're having some chest discomfort. This is the person who catastrophizes is often thinking the worst possible conclusion. And this is happening because they are relying on that as a fact. Next, we will try to understand what is hypothetical worry. Everyone worries, and it's completely normal to worry about little things on a day-to-day basis. This becomes unhealthy when you start excessively worrying about hypothetical situations and scenarios. So, hypothetical worries include mostly what if thoughts, and they're typically about things that you don't have much control over. This is different from practical worries, which concern things you have to control, you do have control over. Whereas in hypothetical worry, you don't have control over your thoughts. You're more likely prone to hypothetical worry if you are very uncomfortable with uncertainty and you spend more time worrying about the future than living in the present. For example, someone hypothetically worries could think, what if someone gets too close to me at a supermarket and I catch the virus? Emotional reasoning is when your mind tells you that your emotions reflect reality. While emotions can act as helpful messengers, they often aren't reliable. In emotional reasoning, emotions is taken as an evidence of truth. In this picture, it is, as you see, it is going off based on your feeling rather than logic. The heart is telling the mind what to do. Also, to give an example about emotional reasoning, it could be, I'm feeling scared, so I must be in danger. Another example could be, I feel guilty, so I must have something wrong. The last one we will be talking about today is fortune telling. This is when your mind interprets predictions as facts. There is a lot of overlap between the previous things that I already talked about. So, fortune telling involves predicting a negative outcome without realistically considering the actual odds of that outcome. For example, I'm going to be stuck inside for another year. If the present situation and if there's a spike in the numbers of the COVID, I'm going to be stuck inside. I won't have much of a social contact with my with my support system. You're making a projection here about the future, but you don't know if it is true. Next, I'll talk about some tools to help manage anxiety. Let's get started with the information diet. Especially in today's world and with everybody going on with COVID-19, that's the only thing you hear on news 24/7, whether it be on TV or Facebook or WhatsApp. Not a single day goes by where you don't see any COVID-19 related messages. The media is fully aware that our brains are built to fixate on threat, uncertainty, and negativity, and they capitalize on it. Anxiety is easily fueled by this kind of information. When we hear there are 900 or 1,000 cases of COVID, we naturally feel more anxious and insecure. To reduce anxiety, it is important to be aware and to take control over the information diet. I know one thing I suggest all of you is to read one piece of good news every day. Some good platforms where you can read about great things happening around the world is some websites called Good News Network, Good, Country, and Townhouse. Another thing you can incorporate into your week is a digital detox, which is limiting your exposure to anxiety-provoking news, taking time away from screen limit, and limiting excessive social media use. As I previously mentioned, anxiety often occurs over things we have no control over. It is important to separate these things into two big categories. The first category contains things that are within our control. These include like building resilience, following the latest information and advice regarding COVID-19, information diet, eating well, getting a good sleep, maintaining a good sleep hygiene, and exercising. The other category is the things that are outside of our control. So those include other people's decisions, other people's health, the news, government actions, flights and holidays being canceled, traffic, aging, or about how to predict the weather. So focus your attention and worry about things that you can control. So this is a quote I read somewhere, and it really stood out to me, and I wanted to include this in my presentation. This is a quote from Epictetus, who was a Greek philosopher. It says, "Freedom and happiness are won by disregarding things that lie beyond our control." I like this quote because it relates back to anxiety and the overarching idea that we can control everything. When we try to, it usually doesn't turn out well and causes a lot of stress as opposed to happiness. The next slide is about thought challenging. There is a technique that can be followed in thought challenging. It's called the ABCDE technique. Now, this is a great technique to reduce anxiety and helps to almost instantly calm the individual down. Thought challenging is an acronym. It's ABCD is an acronym, and I'll guide you through some questions to ask yourself if you are ever feeling anxious. So A is for attention. When you feel distressed, stop what you're doing and pay attention to the inner dialogue. What is your mind telling you? B is to believe. Do you automatically believe your thoughts? So this is the question you should ask yourself. You have to challenge that thought. C is for challenge. Diffuse anxiety by broadening your focus. What's the bigger picture? Is the thought fact or opinion? And D is for discount. Acknowledge that anxiety has been dominating your thinking and let the unhelpful thoughts go away. E is for exposure options. What would be helpful to focus on right now? What options do I have available? The next part of my presentation is on hopelessness and despair. So let's take a moment to reflect on ourselves, and I want all of you to look at these statements and see if you say this to yourself. I'll give you all a few seconds to read it over. Okay, I hope you got a chance to read a few of these. Okay, so now that you have had a chance to look at those statements, let's learn a little bit more about hopelessness. Hopelessness is a powerful emotion that often contributes to a dark or low mood and can adversely affect the way we perceive things, people, and situations. An individual who feels hopeless may often have no expectation of future improvement or success. They can also lose interest in things that they previously enjoyed. They may no longer value things that were once important. Next, what is despair? Now let's look at despair. At some point in your life, you will feel despair. This normally heals with time, but if it becomes an issue when this despair deepens over time, rather than dissipating, if it progresses, then it could lead to a clinical condition called depression. Clinical despair is described as a profound and existential feelings of hopelessness, helplessness, powerlessness, and pessimism about life and future, which are persistent. It can take control, become chronic, and diminish our quality of life, which impacts our day-to-day functioning. You may feel frozen and unable to get anything done. Feelings of despair and hopelessness can not only be overwhelming, but it can be very crippling. I'm sure everyone is familiar with this term, depression. Depression is a persistent state of sadness and despair. This occurs when you are unable to bounce back from a recent emotional setback, becoming stuck in a depressive state. The other major components of depression is that when you observe there are physical changes like weight gain or weight loss, changes with your sleep patterns, not sleeping well, or having too many awakenings during sleep, feeling fatigue or feeling exhausted, lethargic, difficulty concentrating or holding your attention to a task. Depression can also trigger some irrational feelings, specifically some feelings of guilt and shame. Individuals can be withdrawn and isolated. They may also be very hypersensitive to feedbacks or criticisms. They may also experience low self-esteem and low self-worth. Moving on to our last section, here we'll be talking about coping with hopelessness and despair. So I put together a short list of very practical things you can implement in your day-to-day life to build up resilience and keep up your spirits high. Starting off with the first one, scheduling regular breaks. This is especially important for those working from home. It is important to maintain a work-life balance. Now next is writing a weekly goals list. It breaks tasks down and crossing them off as you complete them. Research has proven that if you write down your goals, you're more likely to achieve them. Now, from your weekly goals list, you want to identify 1 to 3 most important tasks. This is what you must prioritize and spend your energy on. My next suggestion is to tidy your workspace where you spend most of your time at the end of the day. Research finds that cluttered environments interfere with your ability to focus. Also decide on having a regular sleep schedule. This is very important. If we don't have a proper sleep hygiene, it can throw us apart in different spheres of our life. Another suggestion is to create weekly family traditions. For example, having movie nights once a week or on the weekends, or having game days on Fridays, or some sort of a ritual with family where everybody is collectively together and spending time. Lastly, be kind to yourself. Remind yourself that you're doing the best you can. This is also called as self-compassion. I personally feel mindfulness also has helped me in many ways. So mindfulness means maintaining a moment-by-moment awareness of our thoughts, feelings, bodily sensations, and surrounding environment. I personally find this very helpful. Lastly, I want to close my presentation on a spiritual note. I was watching a pastor talk about how to stay faithful during this pandemic. There were a few points he was talking about that stuck out to me. So the first thing was distinguishing between fact and feeling. A great way to handle low feelings is to simply say, I am leaving that to God now. I will trust Him to handle it. God is good. The Bible verse that relates to this is, humble yourself, therefore, under the mighty hand of God, so that at a proper time He may exalt you, casting all your anxieties on Him, because He cares for you. It's taken from 1 Peter chapter 5, verse 6 and 7. The second suggestion is giving sunshine to the soul. Oftentimes, the most effective method for increasing your faith begins with your body. So going for a short walk or just simply sitting in the sun can do wonders for the darkened brain and sunken soul. I will close my presentation with this Bible verse. May the God of hope fill you with all joy and peace in believing so that by the power of the Holy Spirit you may abound in hope. Romans chapter 15, verse 13. That brings me to the end of my presentation. Thank you so much for your attention. I know it was a little long, so we will skip on the questions. If you have any, please email me and I can get back to you. I do want to mention a few resources in the GTA. So I'll just go over it. If anyone is having a mental health crisis or having a sort of, feeling distressed emotionally, there are distress centers in Ontario all over. So you can call the distress centers if you Google, you can find distress centers of Ontario. There's also the mental health outreach team, which is called the Peel Mobile Crisis or the 24/7 crisis support. That also is an amazing support. It's through the Canadian Mental Health Association, so they are pretty quick in reaching out to you. Or if you think you are in real crisis and need help, then the best, if you think your safety is at threat or you're feeling you're not coping at all, then the best option is to call 911 or to go to the nearest emergency department to your place. Okay, so thank you. And once again, thank you for listening.
Thank you, Shiba Aunty, for that very pertinent and really wonderful presentation. I think you already answered my question, which was resources or where one should turn to if they need help with regards to mental health. So and if anyone else has any questions, I think she shared her email address. So if you can just email her, she will let me know, and I guess I can share that with everyone, or she can come back. She's more than welcome to come back and share it if she wishes to do so. And so I just want to wrap up with just a couple of points with regards to our theme and topic for today. And thank you again to everyone who's been patiently waiting with today's seminar. We went a little bit beyond original time schedule. And but they say patience is a virtue, right? So those of you that waited till the end were rewarded with the pearls of wisdom that the last speaker shared, because that really struck at the heart of today's and dived into the into the heart of today's theme and topic. And so really just to keep in mind for everyone before we wind up today is that as Shibanti said, cognitive behavioral therapy is a very simple and proven and effective tool that people should not neglect. And it could save you a lot of time and energy and heartache and hardship. And like she mentioned, the CBT, it really makes you take note and take inventory of how your behavior affects your mood. Most people think that their thoughts affect their behavior, but in actuality, it's the other way around. Your behavior will lead to certain thoughts, and those thoughts will lead to your feelings, and then it comes back in a feedback loop where it comes back to that affecting your so forth behavior and so forth and so forth. And so CBT would help you take inventory of that, how your behavior affects your mood, and then it would help you find out how or take note of how your thoughts affect your mood. So behavior affect your mood and thoughts will affect your mood, right? And then just being cognizant of the irrational beliefs that you have, the learning how to dispute some of the automatic negative thoughts that you have, learning how to change those automatic negative thoughts, and then just taking stock of understanding some positive core beliefs that you have about yourself. And those core beliefs revolve around Beck's triad of yourself, of the world, of the future. And oftentimes that's all you need to treat mild to moderate depression. But of course, there are severe cases of depression that really needs further management by a medical expert or professional. And so there are 4 main lines of treatments when it comes to depression that we know of. One is pharmacotherapy, and that's usually the first line that people would receive if they went to their family doctor. But a lot of people are averse to taking medication because of this because of side effects. That is a fair fear to have, because it is true that there are certain side effects that comes from certain medications. And just to give you some statistics, if you didn't know, the first line of treatment with pharmacotherapy, they found that usually only 60% of people responded with a reduction in depression by more than half of the depressive symptoms. Only 30% of people that tried medication first line actually went into remission of their depressive symptoms. And more than 60% actually complained of a side effect. That side effect might vary in intensity from headache or migraines to sleep disturbances or other disturbances, but they did have the adverse reactions. And which brings us to the second part of a modality for treatment, which is psychotherapeutic. And that involves, like we covered today, CBT, talk therapy, talking to someone, a therapist, a counselor, pastoral counselor even. And they would know, because there's so many different methods of treatment, like psychodynamic theory, problem-solving theory, acceptance and commitment. But they all sort of come under this umbrella of cognitive behavioral therapy. And then the fourth avenue, which I think Dr. Joseph sort of briefly touched upon, was we have something called the complementary or alternative medicines. So omega-3 is known to alleviate depressive symptoms. It actually improves the neurotransmitter levels in your brain. Other alternative medicines like St. John's wort is commonly heard of. You might have, and then of course, behavioral changes like yoga, meditation, or something called SAMe, S-adenosylmethionine. So these are also things that you can use, you can try out initially, or you can use them as an adjuvant. And then finally, of course, the tried and tested exercise. Exercise is proven to actually improve your depressive symptoms. And usually, like diabetes, the first sort of method of treatment they recommend is lifestyle modification that includes behavioral changes and exercise. And when we talk about depression, depression can vary in its presentation. There's something called major depression, where you have the severe sort of symptoms. And like it was mentioned previously, you have the gloomy mood, the sleep, the fatigue, the lack of energy, the appetite, the unexplained aches and pains in your body, unexplained headaches, lack of interest in things that you used to previously enjoy, and lack of interest in any of those activities, inability to concentrate, brain fog, memory problems, inability to make decisions, indecisiveness, right? Feeling of worthlessness, hopelessness, constant worry, anxiety, and worst case scenario, suicidal thoughts and suicidal tendencies. And a study in 2010, researchers in Germany discovered that even your vision is affected by your depressive mood, to the point that depressed people have a hard time or more difficult time distinguishing between black and white, also known as contrast perception. And that sort of brings to reality that it explains why depression can make you view the world as looking hazy when you're in such a depressive mood. But that's not the only way that depression can affect you. A lot of times people don't realize they're depressed and they have something called dysthymia, which is less persistent, but it's a more persistent, which is less intense, but it's more persistent, and it's a chronic form of depression. And usually that lasts for more than 2 years before they label someone as having dysthymia. Then you have something called bipolar disorder. You have alternating between periods of manic and depressive moods. And you also have something called postpartum depression because it's associated during pregnancy or within the 4 weeks after childbirth. And that's linked to hormonal changes in the body. Then you have something called seasonal affective disorder, which is common in winter in the northern hemispheres, and it happens with lack of sunlight or lack of vitamin D. And then you have something called adjustment disorder, which is more of situational depression. It might come about with the death of a loved one, an illness, a life-threatening event. And that usually typically happens within a 3-month period of the triggering events. And the thing to remember is that depression doesn't happen in a vacuum. There's usually some element of anxiety that happens around with it. And again, cognitive behavioral therapy is also there to help with anxiety disorders that most people commonly concurrently experience along with depression. And if you think of depression as being something affecting the mind, anxiety is your body's physiological response to stress. And it becomes problematic when it becomes disproportional to the circumstances that you're facing. And again, just to just for the sake of covering the types of anxiety disorders that exist, there's different presentations, right? So the symptoms of headache, palpitations, hypertension, increased heart rate, tachycardia, sweating, spasms. Generally, if it lasts more than 6 months, and you have more than 3 symptoms, is something called generalized anxiety disorder, which is most commonly seen in older adults. Again, it could involve concentration problems, irritability, muscle tension, sleep disturbances, restlessness, fatigue. But another type of anxiety also exists called social anxiety. And that involves with the disproportional fear in social settings or interacting in a social manner with other people around you. Then you have something called OCD, obsessive compulsive disorder, where you have intrusive thoughts and compulsions. A lot of times you hear about people in our community that have hand washing, or they repeatedly count money, or they're worried, they keep checking on the oven because they're worried that they forgot to turn the stove off and the house might burn down, and they keep going back to check it repeatedly. That's another form of anxiety. And finally, we have something called panic attack, which is a hyperacute, severe form of anxiety that people suffer. And most often it's accompanied with palpitations and sweating, and an immense dread and fear. And also recent times in modern day, people have begun bringing to the forefront something called PTSD, post-traumatic stress disorder. You're faced with a disaster, a natural disaster, calamity. You're in a hyper scary environment like war. You're coming back from fighting in a war abroad, and you have these flashback memories triggering a sort of hyperacute feeling of anxiety. So now that we've sort of shed light on what these different presentations of anxiety are. The bottom line to remember is that, try lifestyle changes, omega-3, decrease caffeine, tea, or stimulants, avoid smoking, make sure you get enough sleep, try mindfulness tools, meditation, CBT. Sometimes it's medication, sometimes it's alternative therapy, like kava, which is proven to actually alleviate anxiety, St. John's wort, passion flower, valerian root, and sometimes things that makes anxiety worse: tobacco, alcohol, cannabis, sedatives, opioid, painkillers, stimulants. So I think the other thing that I wanted to cover in winding up and wrapping up this topic is there's a new trend that's emerging in the world today, which is online therapy. And just to share with the audience, I'd like to inform all of you that if you are interested in trying out CBT for depression, there are free resources, and an excellent one is a free CBT for depression, which is an 8-week program that you do completely online. It's put on by the Canadian Institute of Mental Health Services, and the website for that is cimhs.com. And it stands for Center of Interactive Mental Health Solutions. Excuse me. And so those are some tools that you should try, and I think it would be beneficial for a lot of people. And finally, in closing, I just want to say, don't view depression as a weakness. Studies actually prove that smarter people are more depressed. And I guess there's some truth to the saying that ignorance is bliss. An American study done in 2017 by Karpinski discovered that smarter people with an IQ above 132, like those people that are accepted into Mensa, or geniuses, as they would like to call themselves, are 3 times more likely to be afflicted by depression, and twice as more likely to be affected by anxiety. The national average is about 10% for each of those conditions, but these high IQ people in Mensa reported 27% incidence of depression and 20% incidence of depression, so almost triple and double the national average. And that's unfortunate in many ways, and I think the explanation for that is that smarter people are more aware. They're hyper aware of their environment, and it leads to hyper reactivity in the mind, culminating in depression, and hyperreactivity of the body, culminating in anxiety. Every small thing can trigger a response for a person that's ruminating about the things happening around them. And being smart means that you're also constantly vigilant about any potential threats in your in your vicinity, in your environment. And I think depression and anxiety is the unfortunate burden or price to pay. And I'd like to end with a quote by a famous German-American poet and novelist, Charles Bukowski. He once said that the problem with the world is that the intelligent people are full of doubts while the stupid ones are full of confidence. And I think that just parallels to what we were talking about, depression, anxiety, and studies finding that smarter people have higher incidences of these conditions. And I just remember that there, to living life, it's all about balance. Balance is key. We should remember to have 4 pillars in our life. We need to be active physically. We need to be productive. We need to have a social connection with family and friends around us. And we need to do things that are relaxing. Maybe watch a movie, listen to music, play a game, travel. But the thing is that so often than not, we forget to focus and make time in every day for each of those 4 dimensions or 4 pillars in our life. And what inevitably winds up happening is we get so caught up and stressed out with one thing that we neglect 3 of those different aspects or pillars, and we put all of our eggs in one basket. And then when we face a road bump in our life, all of a sudden it inevitably leads to a crisis, and we find ourselves with a major crisis because we don't have the other 3 pillars there to hold us up and to support us. And I think just remember to lead a balanced life and to lead an educated and more knowledgeable life so that we don't have to suffer in silence. And I think we covered the scope of that. We covered, we sort of touched on everything and more than we needed to, actually, with a lot of the neurological background and sort of the insights shared from the health experts we had today. And if you have any questions, please send it to our email address, meaningoflifefellowship@gmail.com, so that we can have those questions in advance of each of the seminars, so we can forward it to the speakers ahead of time, and they can sort of cater to the target audience with what they would like to know more about. And I don't think there's any more questions, and I think we've taken up 3 hours. So please email me if you have anything to say with regards to questions or feedback. And I think because of the internet connection problems in India, Jibinachin, his net cut out. I got a message, actually. So if Jibinachin is not here, then I think I will just wind up with glory to God, right? Barakimor. Hallelujah. Thank you, God, for this opportunity where we can come together and learn from one another that we haven't been able to in the last all of my life, or 2-3 decades. So it truly is a blessing, and it's a time that we need this more. It's more so than ever. And so we'll make handouts, because I know this is a lot to digest in one sitting, and patience is a virtue. So thank you to everyone that patiently waited till the end. I'd like to think that the pearls of today's seminar was disseminated at the end of the meeting. So just stay tuned. We'll make handouts so people can have these helpful tools and reminders ready reference, and they can share it with everyone around them and their friends and family. The flyer for next week will be coming out shortly. We'll have more health experts and speakers, and I think the topic or theme has to do with ethics and value system, a hierarchical value system. And stay tuned. We'll have more details coming out. So praise God. Thank you, God, for this opportunity. Thank you to everyone, to all of the audience here. Thank you to the speakers and the participants. Take care. Have a great week. Enjoy the rest of your week. Practice some of the tools and tips that people taught you today. And hopefully people will come back next week more happier. So stay safe, and see you all next Saturday. Thank you. Bye.